Hello everyone, my name is Robert Hersey. Welcome to today's virtual workshop titled Integrated Community Services for Children and Youth. This workshop is being made available through a collaboration between the Florida Department of Children and Families and FATA. A PDF file of today's PowerPoint presentation and a participant activity guide were emailed to all participants via Constant Contact. If you do not have these documents, they are available now on the FATA website and will be posted in the chat panel momentarily. If you haven't already done so, please take a moment to either download or print these documents, as you will need them throughout today's presentation. Today's workshop will feature both presenter instruction and breakout rooms for small group activities. You will be able to interact with the presenters by typing your questions and comments in the chat panel. Please note we will answer questions as time permits, and we'll answer as many questions as possible. During the presenter instruction, your microphone will be disabled. However, you will be able to unmute during the breakout rooms. Please note that participation in all activities is mandatory. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options you can try. For computer audio, first click the up arrow next to Audio Settings, then click Leave Computer Audio. Next, click Join Audio, then click Join with Computer Audio and follow the instructions on screen. If you continue to experience poor audio through your computer, you may try calling into the presentation. Instructions for doing so will be posted in the chat panel soon. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center at the top of your screen, and click on Training Library. A Certificate of Achievement and CEUs for up to 3.5 continuing education credits are available for participating in today's workshop. CEUs are available for individuals licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for those credentialed through the Florida Certification Board. There are a few requirements to earn a Certificate of Achievement and CEUs for this workshop. First, you must attend the entire workshop and you must have your camera enabled. Second, you must participate in each breakout room activity. 3, you must complete the post-workshop evaluation. The evaluation will populate automatically at the end of today's workshop. We encourage you to complete the evaluation immediately. You will receive a follow-up email in 24 hours with the evaluation link. The evaluation will close in 3 business days. Certificates of Achievement and CEUs will be distributed within 30 business days of the evaluation closing. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenters and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenters today will be Lyanna Alvarez and Emily Jones. Lyanna has over 10 years of experience in the behavioral health field and earned her master's in school psychology from Carlos Albizu University. As a senior clinical program manager, she oversees various grant projects in Seminole, Orange, Osceola, and Brevard counties and helps guide and support clinical staff and managers in their work. She is currently pursuing her PhD in social work, focusing on managing social programs and policies. Emily is a registered clinical social work intern and has been in the field for nearly 13 years. Emily graduated with her BSW and MSW from the University of Central Florida. She has served in various roles, including therapist admissions specialist, targeted case manager, and clinical liaison. Currently, she is a clinical manager for the Orange County CAT team. And now I would like to welcome our presenters, Lyanna and Emily. I will turn it over to you.
Hi, everyone. Welcome. Thank you so much for being here. Sorry, Lyanna. I'm Emily Jones. Really happy to be here with you guys all today.
I'm here, Lyanna. Thank you so much for that introduction. So we're gonna be presenting a lovely presentation. Just a few footnotes. We do have two scheduled breaks today, so if anybody needs to take breaks in between, by all means, please do so. Take care of you. And no need for any ask for if you need breaks or anything like that. So please, be free to do so. We'll have two activities towards the end of the presentation. The first part of the presentation is more so geared towards more of the information that we have provided in prior presentations and during the conference last year. So any questions will be answering in between the two breaks throughout the presentation as well. Alrighty. So the learning objectives that we have for today are, we're going to talk a little bit more about the Community Action Treatment Team, most commonly known as the CAT team model. We're going to talk in detail about what we do, the history of it, how it attaches to the guidance documents, legislation, and how each one of the counties have embedded their own CAT team model. We're going to analyze some of the outcomes, our performance measurements, and kind of like how we work. So that is going to be part of the presentation, and we also gonna do application. So that's where this workshop is gonna be most geared towards, is doing the application portion of how to integrate some of this knowledge that we have about CAT team at different levels, not just at the CAT team level, but how can you apply it to your real life work, and how can you integrate it into your either prior practice, into your current roles, or in the different ways that you serve families and children that have higher levels of need in the behavioral health field. And we're going to have some lovely stories, some case analysis. So we're going to be presenting those, and we're going to be discussing with you guys. And hopefully by the time we get to the application area, we're going to be doing some breakout rooms, and we're going to be jumping into those breakout rooms with you and talking about those areas.
Yes. So a little bit about us. Both Lyanna and I are with the organization Aspire Health Partners. Aspire is the biggest behavioral health, community behavioral health organization in this side of Florida. So we are located in Central Florida. We are right in Orlando. On the screen, you'll see just a couple of little snippets about our services here at Aspire. There are over 165 different programs that run out of Aspire, in all of the counties in Central Florida. So that includes Seminole, Osceola, Orange, Brevard. We also have some services in the Hillsborough County, Tampa area as well. So as you can see, there are lots of different services that we offer here at Aspire, and the programs that we're going to be talking about today, the Community Action Treatment Team, affectionately referred to as CAT. That's just a small snippet of what we do. But I would like to also say that the CAT team at Aspire Health Partners, Aspire Health Partners houses 3 of the county's CAT teams. So we are in Seminole County, Osceola County, and Orange County. There is, as we'll talk a little bit more about as we go through the presentation, there is a CAT team in every county within the state of Florida, because we are written into the Florida legislature. But yes, we do offer a variety of services ranging from behavioral health to substance use and substance treatment. We also work with human trafficking survivors and things like that as well.
So when it comes to the CAT team, as we're going down to the history lane where the CAT team initiated and how this became part of legislation, we go down into 2004, where our first implementation was happening in Manatee County. Where the initiatives of the CAT team process and getting a pilot program over there, where After many instances where families were not able to access services in a more um, variable way, where people had to go to hospitals or had to go to offices to receive services, and also due to the higher incidences of higher risk clients that were in need of more in-home or more strategic type of modalities. So CATIN was implemented in the Manatee County, and the state noticed with the data that was recovered from that, that this was a really successful model and program that promoted well-being and promoted a stability and management of behavioral health for youth and adolescents as well as their families. So with that, it came an evaluation in 2010, and in that process there was a lot of information that was added because there was a lot of tragedies, and as you can see in this timeline, you're going to see a lot of tragedies that kind of like implement that also added into how to implement this and how to make sure that when situations happen socially that we were able to tackle them and be able to um, provide the support that the families needed. Especially with the Sandy Hook tragedy, many students were struggling with this and this whole process in their own communities, and nationwide it was really a high impact to a lot of families and a lot of communities. So obviously as students go to their homes, it affects the family dynamics, it affects their mental health, their social interaction. So with that information, the Manatee County continued gathering data and providing support and in inserting most of the strategies that we commonly use for our programming, which we'll talk in more details in just a few minutes. We're incorporating a more wraparound model where we have not just one person working with the family, but a variety of providers and professionals working together with the family in a higher intensity way of means. So in 2013, as we were integrating that, and the state noticed that there was a high success with that program and that modality. They integrated and implemented 10 more CAT teams to see how it varied around the state, to see more data, more information, and see whether the north side of Florida, the southern part of Florida, central Florida, all these areas, what the difference was in between each of the communities and each of those integrations when they were impacted. In 2018, another tragedy, the Marjorie Stone Dogman Parkland tragedy, also increase the impact of these type of modalities. These come from the action community treatment team. So more collect we do have also like the adult version of the CAT team, which is the FACT team, which is kind of like where it all originated. So as we're going into it, it kind of gave more emphasis of the need towards supporting families and adolescents and children. After that, I love all that lovely data came through. 2019 hit, they expanded to 41 CAT teams across the statewide. To date, we actually have about 69 CAT teams at the first level, and we'll talk more about the different levels of the CAT team. But each one of the counties have their own CAT team. In the DCF portal, you'll be able to access a map that can actually give you the information which ones is the CAT team or the agency that is allocated for that CAT team in your county. And in the essence of that, 2019, as we all know, impacted by COVID. Like that was I would say, another situation socially that happened for a lot of families trying to get services. That kind of like, pivoted our work tremendously, since we're mostly in home, in providing services out in the community to families. So we had to pivot a lot. We had to develop new strategies to be able to serve clients in their homes in a different perspective. So definitely CAT team is always evolving and has always been providing high support to the families, as well as good data and good outcomes to the state to provide and to ensure that this, because we're grant funded, so we're not medical insured, that the funds that are allocated for the CAT teams continue being allocated for the CAT teams. And I think that's where me and Emily, I think, take pride on, that we are able to provide that information to the state and continue expanding, maintaining, and evolving the CAT team as much as we can throughout the Central Florida area, as well as with our sister CAT teams all around the whole state.
Yeah. And just a quick word about the grant funding, because I'm sure that there were a lot of ears that kind of peaked at grant funding, but not all CAT teams are grant funded. We are very fortunate here in the Tri-County area, again, Orange, Osceola, Seminole County, that our managing entity and, the governance under which our CAT teams are funded does graciously come from grants. So I know that there are other CAT teams within the state that kind of have several different layers of funding and things like that, so that the idea is that nobody gets left out of services, because in the long run, what they're looking at is to keeping these kids out of higher levels of care, which is also kind of a large focus of our presentation and what we're going to talk about today, because we all know, right, that is going to save the state more money if we are proactive versus reactive. So our programming and our program, the CAT team, is just designed to keep these kids out of higher levels of care.
So an understanding of what the community action treatment team, we are a multidisciplinary community-based group that offers intensive wraparound services to children, adolescents, young adults that are in their homes due to some circumstances of mental health and substance use disorder. And it can be co-occurring. It can be just one or the other, or at the same time, it could be some family dysfunction, as well as other areas that we're going to be discussing. I think the biggest peep that I like about the CAT team is this word at the bottom, hospital without walls. I think that's the most important part of it, because most of the clients that come to us for services, they're seeing it in the aspect of, we are a agency, we're a hospital. Most of them have been in an inpatient unit or a CSU, so they're already impacted about having to be back in the setting. And the realistic part of themselves is more so in their niche of their community, in the niche of their own homes, and providing the services in their homes makes it a lot easier for them to understand and put the strategies in place in their own homes, rather than we're just in an office doing a session for a whole hour, or we're with the case manager looking at referrals for a whole hour in an office setting, rather than the realistic ways of seeing things as they are. Like, one person can tell you, oh, I have no food, or I have food scarcity, and that means so many things for so many people. When you go into the person's home, you can realize, oh wait, that's what they meant about not having food or having food scarcity. Or a client telling you, yeah, I'm having like really severe anxiety problems, and at home, and home is maybe a hotel where this person lives with 6 other people in the same room, which happens a lot, more than we think.
Yeah, definitely happens way more than, and I think probably everybody in this call can attest to that, right? So a little bit about kind of eligibility for the CAT team, and Lyanna will talk a minute about the different kinds of tiers of CAT team that are offered. But for what we're talking about today, effectively kiddos are coming into our program who are between the ages of 11 and 21. Now, that's not to say, and I always like to say this caveat, is that that's not to say that if we have a 10-year-old, even a 9-year-old that comes across our referral table, that's not to say that they're automatically disqualified because of age. During those times, we may screen them extra cautiously and judiciously to just kind of make sure that there's going to be family involvement, because again, family involvement is so critical, or support involvement, right? Support system involvement. But also we want to make sure that they are cognitively going to be able to have that level of comprehension as well as that level of participation in order to actually be able to benefit from our services. And the same goes for those who are just kind of aging out, right? Because we all know that there's kind of like that gray area of 20 to 22 that oftentimes they fall through the cracks with services because they're not too old, but they're not too young. And so they're kind of, like I said, just in that gray area. So for the purpose of our program, we do serve 11 to 21, and they have to have a related mental health diagnosis. And like Lyanna mentioned, it can be also co-occurring, but the mental health diagnosis would have to be primary for the CAT team. We are also designed, like I said earlier, to keep kids out of those higher levels of care. So generally speaking, we are seeing those kids who are probably those with chronic mental health issues. Maybe they have some of our requirements and our criteria. They maybe have had more than 2 hospitalizations, inpatient psych hospitalizations within the last 6 months. Maybe they've been arrested and they have Department of Juvenile Justice or DJJ involvement. Maybe they are, right on the border of going into child welfare, or they're on the other end and they're coming out and they need supportive services. So any sort of like DCF involvement. Perhaps it's just academic failure. Something's going on that's not quite what they used to be, what these kids used to be, or how they used to be performing. And now all of a sudden, their academics are suffering. And that's not to say that academic failure or struggling with academics is the same thing as truancy. Those are different things. So if a kid is failing or not doing well because they are truant, that's a little bit of a different issue. Of course, we absolutely could screen that person to see if they do meet that additional criteria, but also we're looking at, like, have they tried everything else? Are there failures at lower levels of care? Because we are considered kind of that in between a Baker Act or a residential facility and traditional outpatient. So it's for those folks who are needing that extra support, that are needing those extra kind of wraparound services. That's where we come in and we start with pretty intensive programming.
So as we're talking about the different tiers, right now at Aspire Her Partners, and we oversee the tier 1, which is the 11 to 21. Not to say that it's just a caveat of the 11 to 21, like Emily was explaining. There's the additional to that, like if we have clients that are under the age of 11, they do have to meet 2 of our criteria from our guidance document, which is in any of the ones that Emily was explaining: DJJ involvement, school failure, DCF involvement, any sort of means that it's affecting their mental health and stability in the community, including the either aging out of the Department of Children's Families, or aging out from child welfare, or in any instances where they're struggling. We're still going to do our full assessments, and we're going to go into the home and provide additional support, because again, sometimes they do fall in between the cracks, and we're not going to reject a client just because they don't meet all the full criteria. We're still going to make our assessments. So that will be tier 1. There's also tier 2, which is the Prevention Services Act. Some of the area locations do have these ones. We have the tier 3, 0 to 10. And then we have the tier 4, which is the family support teams. This is a fairly newer one, just like the tier 3, which is the colloquially known as the baby cat. This is for the younger kiddos. Same criteria for our different areas and levels. There's some little caveats, some different changes, but for today's presentation, we're most focusing on the tier 1. But just so you're aware, depending on the different areas, there might be some of your area locations might have these additional levels of care for the CAT team itself. And that will be something that you can explore within the same map that I was talking earlier before, as well as if you consult with your managing entity or DCF, you might be able to identify which ones might be the tier 1, or if you have a kiddo that's a little bit younger and have a little bit more needs, and it's around the age of 0 to 10, and you're in the area location where you do have a baby cat, then may be a good area to explore and actually access those services.
Yeah, and also, like, if you are unable to access the map or you can't find it online or anything like that, you're always more than welcome to reach out to myself. I won't speak for Lyanna, but you're always welcome to reach out to me, and I can try my best to get you into the right place and wherever it is that you need to go. So there's never a dead end.
No. So right now for our CAT teams here in at least in Seminole, Orange, and Osceola County, we do have a staffing of therapists, case manager, therapeutic mentors, psychiatrists, LPN, and then supportive staff. Within those supportive staff, we do have a parent coach that does provide additional support to the families, as well as teaching them skills for parenting, identifying what are the roadblocks for parenting that are getting in the way of managing their kiddos. Our therapeutic mentors to go into the community and provide services, as well as our case managers and therapists Our therapists are master's levels, and they're under our licensed clinician, which will be in our situation will be myself. They're overseen by me, by Emily, and my different managers in the different areas, as well as they do have to participate with our management, which is through our psychiatrists and our LPN. Both are licensed, and we do have our within our programming and our staffing, we do have a child and adolescent psychiatrist. We're pretty blessed to have one in our team. They're really scarce, so having a child psychiatrist in the team that can provide that attention and that specialized attention to clients that need that mid management and can be provided with a specific a doctor that does specialize on that is an amazing thing. Our mentors does, I think, an amazing job when it comes to our services. These are individuals either with or without lived experience that they understand the kids and they actually see the kids and the backbone of, and you're gonna hear me and Emily talking about the backbone of the CAT team. Mentors are the backbone of what we do. In therapy, we process, we talk about the skills, we coach clients, we support the family in a therapeutic setting. But when it comes to incorporating those skills within the community, the mentors come in and do a fabulous job to go out there. And, any barriers that can get in the way, they're the ones that, with the kid, just climb them out and just go at it and make sure that they're not existent. Same thing for case managers. Without them, we also wouldn't be able to identify even sometimes those roadblocks are getting in the way. They go in and they assess the family for their needs and make sure that whatever those needs are, that they can actually have the resources and the referral that they need for those additional needs. Because again, in therapy, we can talk away many things in therapy. We can coach, we can process many things in therapy. However, there's some circumstances and some social situations that we're not able to, and there has to be other professionals providing that additional support. For instance, there can be some situations where, I'm just thinking about truancy, for example. Maybe transportation is an issue. Family doesn't know how to go from point A to point B, and they just don't know. Maybe they just recently moved from another state and they're just here trying to navigate the system itself, and they don't know how to transfer maybe a medical insurance down here. Maybe they don't know where the food pantries are. And those are things that our team goes in and actually helps the family with. And those could be the roadblocks of why we have these chronic mental health situations, because the families themselves don't know, or don't know how to access or strategize to help and support their families. And I think that's what our biggest things for our team does: incorporate, collaborate, and make sure that everybody is supported, not just the identified client, but the family in general. We go in, we assess, we identify, we process, we support, and we make sure that they have the skills by the time they finish with us. Sometimes, just this morning, I got a call from a past client asking, "Hey, do you guys still have some services? I might need some services." Of course, like, we're here to support the families as much as we can. And sometimes, even after treatment, they reach out to us. "Hey, I lost the number for the food pantry just down the road." Perfect. Here you go. Here's the resource all over again. And this society is ever changing, especially Central Florida. I don't know if all of you guys are from the area. The roads are always changing. There's always a construction somewhere around, and with those changes comes restructures of the system itself. So the families might know something from last year, but this year might be something different. And our staff makes sure that the families have that access to, okay, so if anything changes or anything just shifts from here to there, they know where to go, and that they're sustainable at the long run. Not and to prevent them from being in a higher level of care. I think most adolescents or most children don't want to be in a higher level of care. Most families don't want to interact or get into that higher level of care, although needed sometimes. They just want to make sure that they're able to support their families and being able to be there for them.
Yeah, exactly. And just a word kind of about the supportive staff. Our supportive staff here in the Tri-County area are, like Lyanna mentioned, it's a parent coach. The DCF kind of left supportive staff as a general kind of staffing option, only because, and I'm sure, many of you run into this and you see this and you know this, but only because, what is needed in Orange County may not be what's needed in Levy County. Maybe Levy County needs an educational liaison, or maybe, I don't know, Broward County needs a wraparound specialist. So those are kind of at the discretion of the population that's being served. What is going to make the most sense? What is going to break down the most barriers? And what is going to provide the most amount of support? So the support staff, again, for us as a parent coach, we find that there's a great need for that here with our teams. But again, it might not be the same. So if you hear of another CAT team, or you start talking to another CAT team and you're like, yeah, we're really excited about the parent coach. And they're like, what are you talking about? Just so you know, the supportive staff is at the discretion of the organization. Sorry, did you want to talk, Lyanna?
No.
All right. So some of the services that we are offering, as everybody knows, like we've talked about, the case management, the mentoring, the therapy. But what people don't see, and what people maybe, goes off of the radar, is that we are always collaborating. Always. We are always talking to our psychiatrist. We are always talking as a team. It's so important, that because we are sharing caseloads, because everybody's kind of got their own hands in the pot, that we are always communicating. Because what we have found is that the mentor might hear something that the therapist has never heard. Or the case manager might hear something that will definitely impact and has an impact on our kid, but the kid has no idea, right? So through these almost overly communicative, collaborations within the team and within that team environment, not only does it build really strong cohesion in the team, from a managerial standpoint, but it also deepens that idea of how we operate within a wraparound model. The idea is that we are going to wrap that family in services and hopefully heal them from the inside out. And our assessments are ongoing. We don't ever stop assessing, right? Just like we always start discharge planning from the very beginning. Assessment is ongoing. But again, we are looking and hoping to, like Lyanna mentioned, break down some of these barriers, like transportation, if that's affecting school, like food insecurities. We all know what the very first thing when you're getting ready for a test at school, what do they tell you? Make sure you have a good breakfast, right? Your brain doesn't work as well if you don't have a good breakfast. But some of the people that come to us, they don't know what that looks like, right? So those are just some of the services that we offer. We also offer a crisis intervention. Now, that's not to be mistaken with being a crisis team. And also kind of just taking a minute to define what a crisis is, right? Because we also have a mobile response team here at Aspire who the CAT team, uses a lot. So we will call them if it's a matter of life or death, or a suicidal or a homicidal, or perhaps even a psychotic person, or somebody who is just needing that extra level of support. Again, through our collaborations, both within the community and within our own organization, we're able to kind of intervene at a crisis intervention, in that kind of timeline. And then also, once somebody is coming out of a crisis, let's say they were recently hospitalized, crisis intervention doesn't just stop. Right. So what we're able to do as the CAT team is that we're able to go in and we're able to say, hey, you know what, this person's just getting out of a hospitalization, and they've had a lot of stressors. They need more services, right? They could probably benefit from an extra hour of therapy a week, right? Just for check-ins, just to see if they're okay, just to process maybe something happened at school. So when we look at crisis intervention from the CAD team standpoint, those are the kinds of things we're talking about. We will ramp up services once the crisis has been mitigated, right? So once maybe the arrest has been made, or once the child has been discharged from the hospital. Sorry, go ahead.
I wanted to add for the crisis intervention, I think this is important as well when it comes to, if we're talking about, since we're grant funded, we don't have to go through those pre-auths. And I think that's something important, because sometimes you do have other programs that do go through medical insurance, not to say that they're needed, because they're highly needed for our communities. However, we have the benefits that we don't have to go through a pre-auth authorization for maybe a TBOS of increasing sessions and services. So when it comes to crisis intervention, we're able to provide, maybe instead of that traditional 1 hour, 1 hour and a half a session once a week. We can increase that to maybe 2 sessions, 3 sessions, whatever is needed in the moment, so we can have more hands-on, so we can provide that additional crisis de-escalation to make sure that the client doesn't re-engages back into a CSU or back into an inpatient unit, or increases on the amount of bed rest that they can get on a monthly basis. That ultimately will take them into maybe a higher level of care. We're on that prevention at that point, and we're making sure that we're assessing, reviewing, and collaborating. We have great relationships with the different CSUs around here in Central Florida. Whenever we get a client that gets discharged, we get the paperwork, we get discharge paperwork. If we don't have it on time, they usually give us a phone call. Hey, do you receive the referral that I sent over? Do you got when is the client's next appointment? So they're aware. So we're in this constant communication. We do a lot of release of information, so we are able to get them engaged and don't have to be chasing down the caregivers from the get-go. So from the intake, we're signing up a lot of release of information, so we can have a lot of contact and communication across the board, since this is a higher level of care. We make sure that they are all on board and they understand like the need of that, so they're not in the midst of a crisis trying to get some releases, trying to get some paperwork, some discharge paperwork from other organizations or the entities or the collaborators. Like we want to make sure that we are all on the same page and we're actually supporting the families at all levels, and whatever that is needed. If that's maybe 3 sessions, 4 sessions in a week, if we had to, maybe situation that was a suicidal situation where now the client needs a pill case and needs to be delivered medication, we have done so in the past for that medication management under the discretion of our psychiatrist, and he does instruct us how to proceed with those processes. And it's about collaboration and within all these services. And we're gonna talk more in details about the different collaborations that we do have, but I think it's something about the team is that they're highly collaborative with any system, DCF, DJJ, the schools, everybody involved in the whole process of the case itself, not just internally but externally. And we actually pride ourselves in being able to communicate, collaborate, meet, and just disseminate the information, and we're all on the same page. It's not like one system is pushing and pulling. It's all of us helping the family oil the gears so they can function and be self-sufficient within their own system itself.
Yes. And there was a question by Reverend Robin Clark asking if we are not the emergency like EMS that arrives on the scene. We are not. We are not those folks. Ideally, and most of the time, if we are calling our mobile response team, or the family is calling 911, chances are they're already involved in our services most of the time, especially if we're catching wind of that. Oftentimes I will have, staff who are like, okay, this kid's in crisis. We're going to go and just kind of see how bad it is before we need to call mobile response, or before we need to call, 911. Let's go, they may go out and see if they can de-escalate the situation first. If not, and they end up being hospitalized, then we are there to offer 100% support, when they are discharging and coming out of that.
So linkage to services. Oh, sorry. So linkage to services. We're talking about like the care coordination. I think this is what we've been talking mostly about, is the coordinating at all levels. I think when it comes to the CAT team, we make sure that the family in all aspects have housing, education, linkage to natural supports. Primary care is highly important. Some of our clients come in and they're either underinsured or not insured, and at that point, they have never seen a PCP in 10, 5, you name how many years. They haven't seen a dentist, they haven't seen a primary care, they haven't had any shots for the vaccinations. Like, they haven't had a lot of services that might be impacting their mental health, not necessarily at the mental health level just, but also at the physical level, where they haven't even been able to attend those services. Or that linkage to services. We have some families that are involved with the justice system and they don't know how to access, for example, interpreters, or they don't know how to access a lawyer, an attorney, or someone that can actually consult and support them in the process of that. In education, we have clients that are aging out of the foster care and the child welfare system. They don't know how to access maybe grants for college, maybe what else is there outside college, or what is available for me if I'm aging out of the system, but I don't want to go to college. What is there available? I don't want to finish even high school. Is there something else available for me that is not high school or school related? So we make sure that they get all the coordination regarding their stability and also in all levels, which goes in tandem with the crisis intervention. I think when we are talking about the crisis and as what we're talking so far, is making sure not just that we go as a preventative care for linkage of services, but that they know where to reach out to, where to go, who to call, who is a good area to actually, whenever I'm feeling this way or that way, how can I actually manage my own crisis in a healthier way rather than to just let it be and get arrested, because most instances clients end up being arrested and being taken to a CSU rather than knowing, oh, I can actually do a walk-in to go for maybe my own self for a Baker Act and or a Marshman Act myself, but instead of waiting for maybe other systems to get involved, and now I have a arrest charge, or I was combative because I didn't know that there was other options for me to manage my crisis in a situation that I needed it. And all goes together. So one thing doesn't go away from the other, because managing everything when it comes to that, again, not knowing and not being able to coordinate it is what's going to impact maybe their outcomes when they're outside of our programming and the interactions they have with the different systems. It comes to some of the clients I used to have when I first started in the CAT team is some clients will be afraid to even take themselves into a voluntary inpatient or go to a CSU because they were like, oh, there's going to be a record, they're going to see me a different way. And it's taking away this the stigma of, hey, managing your crisis is part of your care coordination as well. It's not just one thing, it's both at the same time. And being able to care for your mental health in a situation where you're maybe experiencing an emergency, or you're having suicidal ideation or homicidal ideation, that you're able to care for yourself and able to go to, I call it like going to the emergency room. Like when you're having a struggle and you do need to go to the emergency room, we don't stigmatize going to the emergency room as much as we stigmatize going to maybe a CSU or going to an inpatient Baker Act facility. Like that's as much needed as going, take care of your own body, of your own physical health. Your mental health is highly important. So care coordination just doesn't come with just, okay, primary care, coordinating with housing and school. It's also coordinating for mental health, like how to manage that in a healthier way, that you have access, that you have availability, and that there's many options, not just a single option for you to be able to care for yourself.
Yeah, I'd also like to take this opportunity just to say that Aspire, and I'm sure you guys have heard this as well, maybe not specifically about Aspire, but Aspire is also a CCBHC. So we are a certified community behavioral health clinic. And that's really cool because it literally is a one-stop shop. So not only can your behavioral health supports come from within, but also your primary care, run of the mill, medical supports can also, be siphoned through the programming here as well.
Another part of the linkage of services is also that linkage to treatment for mental health and substance use. Yes, we already provided within the programming, but once the program is done, and I think I tell this to all of the clinicians and all the staff, all the clinical staff, is once you finish our program, there's always gonna be maybe a need for maybe continuum of care, making sure that those referrals and the clients know how to access and that they have sufficient information to, let's say we send 3 referrals, but they're not, I don't want that referral, that they know what other options are available for them and that they can actually have a choice when it comes to their own services. Let's say they went and they actually, because you still have to play chance and like, oh, maybe I'll like that services, maybe I won't like that service. They go there, they're like, no, maybe I need a different type of services. We get them options in a combination of what we recommend in the clinical setting, as well as the recommendation from the case manager, the mentor. Everybody has at least some information, including the family and the client being served. And and they still within that choice, and they can actually refuse. And the thing that happens quite often when they refuse, I don't want to continue in an additional service, we'll still provide them with a list of services of what is available, either under the insurance or outside insurance and other funders as well for them. Um, Attached to, I would say, to all of our services across the board, psychoeducation is one of the most important part. Like it's difficult to treat something if you don't know how to treat it. Like, if you don't know what does, for example, bipolar disorder, depression, anxiety looks like, or what are those symptoms that we're looking into, and understand it at least at a psychoeducational level, it's really difficult to know, to make the puzzle fit and understand why is cat team coming in, or why is the therapist recommending this, or why is even the psychiatrist recommending this type of medication or these type of interventions. But when it comes to psychoeducation, we teach and coach everything as much as possible so the families know how to treat. Not knowing is one of the biggest stigma and the biggest bias that we can have in our treatment modalities and our evidence-based practices, is because, again, if you don't know, it's difficult to understand. When I'm going through a crisis, when I'm going through, maybe one of my symptoms is increasing because something changed and something is shifting. If I don't know how to treat that, how to manage that, it makes it a lot more difficult to even process something within the services and being able to manage it, especially for parents. Most parents have not dealt with this in the past, and some of them have, but most of them, this is their first time around dealing with these different symptoms, different diagnoses, and they're maybe trying their best as with the little information they can find themselves online. Now everything is really accessible through internet and through different AI systems. However, sometimes it's better to sit down as a professional and sit down with the family and provide them with most accurate, most up to date information so they can actually access that and being able, oh, okay, so that's what it meant online, or that's what, when I was reading it or I was watching this workshop or this person that was talking about, that's what it meant. And kind of taking it back to their own case, because each person's, even though there's a lot of information that goes for a lot of things, each person is individual. And when you individualize that information for that specific family, for that specific child, and you compartmentalize it and take it to that level for that caregiver, it makes it a lot easier for them to process it. It makes it a lot understandable. We are on the professional setting, so we might understand it a little bit better, but taking it into maybe a caregiver that might be a grandparent. They haven't been raising this kid, and now DCF took them into their custody, and now they're with them. Now they're in their homes. They never were there involved for the full rest of the time, and now they have this child back in their home, and they probably stopped being a parent for 5, 10, 20 years, and now they have a child back in their lap. And how can they actually manage something that they never know how to manage? Psychoeducation for me is one of the most important when it comes to treatment. Like, not knowing, it's really difficult to know how to treat.
Yeah, and I think a big part of psychoeducation too is providing psychoeducation for our clients themselves, because so often they may think a certain behavior is normal or a certain behavior is not normal, right? And we won't get into the semantics today about what's normal and what's not, and if normal is real, or all those kinds of things. But that psychoeducation piece really helps kids and adolescents really understand what's going on with them, especially when we get into the more clinically significant mood disorders, like the bipolars, or the precursor of the DMDDs, and helping them identify, like, yeah, no, I mean, yeah, you're no wonder you are so tired, you haven't been sleeping, or things like that, pointing things out and just planting those seeds, and relating things right back to everything that they have going on and everything that we're helping and assisting with and providing support for, so that they can start kind of having these kind of aha moments for themselves, because they don't know what they don't know, right? Just like all of us, we don't know what we don't know until somebody tells us. So I think that the psychoeducation piece is, super important, for the families and the clients themselves, alike. Um, so when it comes to linking to respite care, now we at Aspire, we do not offer respite care, but we are in cahoots, if you will, with several other different organizations within the community that do provide respite care. And for respite, for those who may not be super familiar, it's just kind of like a short-term stay. Typically, a kiddo might go to, let's say, there's an organization here in Seminole County, Boys Town. Let's say that, everybody in the home is just having a really hard time. The parents are exhausted. Maybe the parents or the caregiver's health physically is deteriorating because of, just the amount of stress that, has been instilled upon them, right? Because of their environment and the just overall what's going on. Equally so, that's also impactful for the client, right? For our kid. And so maybe sometimes, we help them kind of make those difficult decisions about, is respite care like a good idea for you guys? Do you guys both just need some time away just to hit reset and come back, and then we can kind of pick up where we've left off. So typically, respite is offered when there's not a whole lot of behavioral concerns. We don't have concerns that, a client might be suicidal or homicidal, right? Those is not necessarily respite, right? But that goes somewhere else. But the respite care is really important, and it can be really kind of reinvigorating to a family system as a whole. One of the other things that we do, as you can see, as we and Lyanna talked about earlier, is the linking to transportation services. Whether that means we are taking the clients, not in our personal vehicles, please, never in your personal vehicles, but we are taking the clients maybe to court. Otherwise, they may miss their appointment, or they may miss their hearing. We may be taking them. I have a case manager right now who is making appointments for next week to take a kiddo who just aged out, right? She just became an adult. So she went from that sweet spot of 17 to that all of a sudden like gray area of 18. And she realized that, she's never had her birth certificate. She doesn't have a social security card because, someone said that they gave it to her and she doesn't have it, and, the back and forth, right? So we're going to take her there, and we're going to sit with her and do that with her. Sometimes it could just be something as simple as, mom needs a bus pass because she has a job interview. Or a client's car, a family member's car is, in the shop indefinitely and they need a month-long bus pass. Okay, that is okay. We can help. We want to try to eliminate all of the barriers that we possibly can to set them up for success.
So now we're going to be shifting gears a little bit into the collaboration that we were talking earlier. And these are some of the areas that we tend to collaborate the most with. And bear in mind that this is how we see it here in our organization, in our CAT teams, and where we're working on the different levels of collaboration. I think the most known collaboration will be our SIP process, or our state inpatient psychiatric programs, that we tend to collaborate a lot with a local or our state LRTs and our SRT. So we do collaborate with them a lot through DCF and through our medical insurances to make sure that the clients, can get this service, but also to explore it. And something I tell this to our managing entity. I love going to these meetings just because it brings everybody to the table, even services that are not already involved in the case itself, to consult and see what other alternatives might be there, or what other options might be available for them in those spaces. Because again, sometimes it's just families doesn't know what other things are available before exploring a SIP, and sometimes they just go to the website and they see the word SIP and immediately like, oh yes, I'm set up for this and I want to do this right from the get-go, which often and on will create more divots into the services, into the progress, and to the stability of the client. So we always try our best to, like, once we're in those meetings, actually have one coming up next week that actually we usually get invited quite often on a weekly basis to kind of talk about it, like, especially with the clients that are heavy users or transition clients that come from one program to the other. And we just want to make sure that everybody's on the same table, talking and conversing, and having maybe a consultative mindset of like what is available and what is the most appropriate level of care. SIP is mostly for clients that are under Medicare and Medicaid, so it's not necessarily for for private insurance or any sort of other insurances. Although there's caveats to that, some of the counties do have other caveats where they do get enroll clients into these other into the Medicaid programming, so they can get benefits from the SIP applications. But again, that's also another collaboration and linkage of services, and it's at discretion of the managing entity, and they support that in this process of that supporting that process. Um, for the Baker Act, again, like I was saying earlier today, we collaborate with a lot of individuals in this space. And we have marked here the ex parte. We in that process, we collaborate with the courts, we collaborated with the officers, we collaborated with the family to get them to step by step how to get from point A to point B, as well as with different organizations here that do carry their own CSUs and making sure that they can provide us information, we can provide them information. Some clients just, stay the traditional 72 hours hold. Some clients that do tend to stay a little longer. We always try our best to visit them there so they know that we are still here supporting them. And we support the family in that whole process. We still, continue to work with the caregivers and making sure the collaboration happens, that there's conversations across the board, up, down, and sideways. It's not just a one way. And then juvenile detention, we have our lovely teen core in our different counties that we collaborate really closely when it comes to the cases. And something about the teen court, sometimes they finish teen court, for example, and it doesn't mean that because they finish teen court immediately they get discharged from our programming because they got involved into teen court. We like to make sure that they're stable enough to step down and that they're able to finish our program even if they finish teen court, and that we can support clients in that process. We send at least on a monthly basis on teen court our core updates so they know what we worked so far, how many sessions we've done so far, where the client is at in our services, and we do that full collaboration. The family knows about our reports to the core system as well, and they know that we're in the process. Me and the other managers, we tend to go into the core hearings and the core staffings in the mornings, usually the days they have allocated for that. Different counties, different days that they have for that. But for us here, I try my best to go on the Wednesdays and Fridays, depending on which of the courts is that day, to give a more live update, but we still provide that monthly update to the court themselves. Child welfare, all of our funding comes from child welfare mostly, so we have to collaborate really closely with child welfare. When it comes to this, we do have to have at least a shelter order or a in order from the court that states where this child is staying and who is the identified legal guardian. I think that's important because when it comes to our services, it's not just, oh, here's my kid, fix them. It's more so, let's all participate all together. Let's get all together, the family, and let's make sure that they can actually function and provide the skills that they need to. Sometimes with that, we do have clients that are in this transition in when it comes to foster care. Those transitional foster cares are a little bit more tricky to manage. However, we try our best to provide services regardless and to provide those assessments as best as we can. Same thing as we do with the courts. We provide monthly updates to the DCMs and to anybody that's involved in child welfare so they know where we at. And if we need to be in the family meetings, we will be in those meetings as well. Family dependency is also a little tricky because it also comes with the family dependency and drug court. So when it comes to that, making sure that, again, we have that shelter order things. I cannot stress how much importance it is the shelter order, because if we don't know where the child's staying or where the child might be staying or who is the legal guardian that we're going to be in contact with, it makes the process a lot difficult. And I think with the new changes to our own structures of the guidance document and how we're supposed to be working in the CAT team, not knowing where the client might be and getting a little bit more clients from DCF and from child welfare, it makes it a lot more difficult to kind of provide services. Stability in anybody's life, just to be quite honest, is the most important thing when it comes to collaboration. We cannot collaborate with a kid that is staying today in Orlando and tomorrow is going to be staying in Tallahassee or Jacksonville or Miami-Dade County. Like, that makes a huge shift because then we have to be transferring a client from one county to another county. We are jurisdictionally attached to the county that we serve. So when we have a client served in Orange County, we serve in Orange County. and if they move into another county, we transfer them into that next county. So interoptional services. That's why it's so important maintaining those shelter orders up to date and making sure that we are informed about those different areas. Um, I think that's on regards of the collaboration. I think these are the biggest parts of that, and making sure again communication and responding. I think our team does a fair way of responding quite rapidly. I mean, if you email me, you're gonna receive an email like in the next 5 seconds. Because I like to communicate quite rapidly. I don't like to make sure that you guys are not waiting, especially with our clients are so high risk, that we are able to maintain that communication and open communication as much as possible. Again, that's one of the main reasons why we make a lot of release of information to our families, so that way we can communicate across the board. I mean, ethically and legally, we are bound to make sure that those things happen, so the families understand. Like, we're not just coming off, or we just don't want to sign a release of information just to sign it. We don't want to be in a situation where the family's going through a crisis and now they're just focused on that crisis, and now we're asking them, hey, can you get me this document signed, instead of us just being already having that already signed and just being there with them through the crisis, holding their hands and supporting them. Which I think in a situation like that, that's where we are our biggest role comes in. It's being a supportive stance for that family, rather than all right, let's just gather some more signatures when they're already making lots of signatures when it comes to that additional services.
Yeah, and one thing, if I can, about collaborating when kids are in a SIP placement. Here with our teams, we do not discharge. Just because a kid is in residential for an undetermined like amount of time, we are not discharging them just because they're in residential services. Because I'll tell you what, those kids are going to need services when they come out. That family is going to need support when they come out. So we do not discharge. We are attending virtually, if possible, those treatment team meetings that are happening in the SIPs, especially gearing towards the last, before the last 2 months of discharge. We want them to know, and the families to know, hey, we're still here. We are still going to support you. We are still going to help. We are going to help reassimilate both of you guys back into the community and in the home and back together again. And we receive the medical records from the SIPs when they discharge, and our psychiatrist, he collaborates based on what we have, run through in the clinical documentation that's come out of those medical records. So that is something that's super important. And I think it's really unique, because I think a lot of times, when a kiddo goes into SIP, they come out and then there's that kind of a lag in between, when they're going to be able to restart services. And oftentimes they have to restart services. So there's a brand new intake, there's brand new paperwork, there's a brand new this, there's a brand new that. With us, hey, we're just happy to see that you're back. Let's jump right in. Right. And we have that history. And, oftentimes it's really nice for those kiddos to see a friendly face or hear a friendly voice during those treatment team meetings, because they don't feel forgotten. They don't feel, so terrible about having to go to SIP, right? Because not everybody wants to go, right? Not all of our kids see or recognize that need, that for, a higher level of care. Also, just a quick word about those kids who are covered by commercial insurances, as I'm sure that some of you have run into this as well. Those with commercial insurances or non-Medicaid covered or insured clients, there's kind of a little bit of a gray area in terms of getting them into residential care. It's not impossible, but what we have found is that it typically is not as long as a SIP placement is. It ranges anywhere from 4 to 8 weeks, generally speaking, if they're covered by an insurance that's not Medicaid. But again, the same rules apply. We will support them through that process, as long as clinically we agree and we think that is the best option, and maybe even the only option. But we support and we don't discharge unless the family, that's the difference, right? Unless the family specifically says, no, we know we're moving to Alaska, so we can just discharge now. Okay, we just document accordingly and move it on out. I also wanted to say that I mentioned earlier that assessment for us is ongoing. We are always assessing, and we, like everybody in this call probably knows, and I said before, that discharge planning starts in the very beginning. No matter what, because CAT team is unique in terms of being both a step up and a step down program. Whenever somebody does discharge from us, we never, ever discharge them with no referrals. We want to see them continuing their treatment journey and their journey into the better side of mental health and substance use. Whether they continue those services, we don't always know, right? But we make those appointments. We make sure that there is as much of a warm handoff as possible, whether they are moving on to a different program within Aspire, most of the time not, or they're going into programs within the community. We want everybody to feel supported and know that the journey doesn't end here, right? So, with SIP, like everybody's favorite conversation. So, SIP has a couple of different steps towards the process, right? The very first and probably one of the most important steps in the process of getting somebody into SIP is first identifying that need. I think that there's also as many people actually genuinely need SIP, there's as many people who don't need SIP who feel like, or somebody in their life thinks that they need SIP. But the reality is not everybody needs SIP. Not everybody needs that, such a restrictive setting. But as you see, some of the needs and some of those kind of things that we base that need off of on your screen. So we're looking for those kids who, are in and out of the hospital, in and out of the hospital, in and out of the hospital, no matter how many supportive services are in place. Maybe it's, and then this is something I see on my team, is that sometimes, we have no choice but to send a kid to SIP because last month, even though there were 31 days in the community, this child only spent 5 days in the actual community because the rest of the time, 26, 27 days, they were either hospitalized or incarcerated. That demonstrates, and you can see the actual numbers, hey, that is a need, right? Sometimes it's in extreme crises, major events, and sometimes, Lyanna mentioned an LRT, and I'm not sure if everybody knows what the LRT stands for, but it's a local treatment review or local review team, and it's basically, like Lyanna said, it's everybody coming together from the community to identify this need and make sure that this is the need, to make sure that there isn't something else that we haven't tried before. And to make sure that this is what this kid really genuinely is going to benefit from.
And sometimes, and to expand onto that, that SIP placement recommendation, sometimes, the psychiatrists do come in and they do their evaluation and they notice, oh, yeah, this client does definitely needs that higher level of care. And with that authorization from that psychiatrist and that recommendation from the psychiatrist, we can start working towards that SIP application and that SIP placement. And another aspect of this, because I know probably this is just a brief description of what SIP placement is, and we experience it in the CAT team quite regularly. That we are kind of more familiarized with the process of it. But I will also suggest, if you guys have any questions like specifics about the SIP application, reaching out to your managing entity for your location, they'll provide you with more information of what is needed for your area. Just because, again, each area is different and each managing entity can support you a little bit different than ours over here. But we are so accustomed in the CAT team to working on SIP applications at least on a yearly basis. And it's a tedious process, I would say the least. It's really intensive, really involved, both from the families and the staff. So it's not just a one way and you just fill out paperwork online and call it a day. Like it takes a lot of process, information, documentation, recommendations, and a lot of information that has to be collected. Often none by the case managers from our team and to make those collect all that information. And there's different staffings that we hold. We do either a local review team staffing, we do our own internal staffings with our psychiatrists, we consult with our managing entity, we do a lot of staffing when it comes to these placements. We don't want to take these placements lightly at any given sense. We want to make sure that this is the best placement for that family and the best course of treatment, and is clinically sound for the symptoms that we are observing and the circumstances that the clients are experiencing in that moment. This is highly restrictive when it comes to, more so than any other level of care. So it's not just the traditional outpatient. We're talking about a place that a kid gets sent to. They're there for about 3 to 6 months, depending on the area that they're going to. So it's more restrictive. So we are always cautious on making a huge recommendation like this. And in my perspective, this is one of the highest recommendations that I can make, and I don't take it lightly at any given sense, and making sure that the family fully understands what this stands for, and it's not just a one-stop shop that you can send your kid to and they're gonna come out and they're gonna come out really stable. Like, most reality is that they're gonna be a little bit more stable, more manageable to come back into the community. But bear in mind that we live in an ever-changing society where 6 months for us out here in a non-SIP placement might look a lot different from a kid that is in a SIP placement. They're not in tune with what's happening out here, and once they come back, that's why we don't close the cases. We maintain the case open so that when they come back, they can reintegrate back into the community, and they can actually attune back into the community with the skills that they learn, with the stability that they gain through that whole process. Because again, it's really, really difficult to go from one end to the other. And then in that process, I mean, the biggest collaboration that we do in this process is with the managing entity, as we're collecting all this information, all this data, all these recommendations and letters from the psychiatrist. Like, there's a lot of processes. Managing entity is the one that provides us the most process of this, and we're blessed that our managing entity kind of provides us at least once a year, if not more, kind of like the process of the SIP placement, because again, it's tedious, it's long. And we had to, once that is approved, the managing entity takes care of that and sends it to the different SIP providers. We don't have that many SIP providers, just to be quite honest, around the whole state of Florida. So it's first come, first serve. And in that process, of sometimes families like, oh, I don't want to be here, I don't want to be there, supporting the family, advocating for them to understand, like, SIP is one placement. Let's try our best to pick the best one for you, and let's try our best to pick one that will be the best option for you. Often none if denied for SIP, because again, throughout the consultation, throughout the whole process of the SIP, they might not qualify or might not meet all the requirements to be in a SIP placement. Often and none, they might recommend outpatient services or recommend CAT teams as an alternative, to make sure that they had tried as much as possible different type of services, different type of modalities that could actually benefit the family a little bit better. So again, it's always the preventative mindset of not having a client in a such restricted environment. Again, it's not a walk-in hospital that we're sending a client into, where we're talking about somewhere that they're not even familiarized with. Some of our clients live here in Orlando and they have to go to Tequesta or down to Miami. They don't know much about that area, that location, and by the time they get there into the settings, it might be a little bit more uncomfortable. They might not fully understand. So it's making sure that if that's something we're aiming to, that the family's fully aware of the ins and the outs and how this is going to look, how is it going to impact. We're still providing services to the family, because the family also needs that additional support in that whole process while the kid is in the SIP placement.
Yes. There was something I was going to say about this. Oh, I was going to say that, sometimes, and I know, again, I've been saying this all afternoon, but like, I know that there's people in this call and in this meeting that have had the similar experience where a family may not believe us, right? A family, we are saying, hey, I don't think this kid is not meeting criteria for SIP. A family might say, well, I really want them in SIP. This happened to us probably about a year ago. And so mom was adamant about, wanting this kid in SIP, wanting this kid in SIP, wanting this kid in SIP. This kid didn't meet any criteria. He met enough criteria to be on CAT team, but he had been doing well. And, a couple months in, 3-4 months in, she was just very adamant. They bumped heads a lot, right? So they really needed that parent coaching. But they bumped heads a lot, and she, looked up online. Google is everybody's best friend, and she Googled, SIP placements in Florida, and she found a facility, and she just discharged the kid from us. She called us and said, what, thanks for your help, but you guys haven't helped, so I'm taking him to SIP. We were all very confused, thoroughly confused, because none of us had, recommended that. None of us had worked on the SIP application, none of those sorts of things. Come to find out that a couple months later, Mom was calling me back and saying, hey, they didn't keep him at SIP. Why wouldn't they keep him? She was really upset. She tried to get him into residential on her own, but again, because of the process, it kind of unfortunately wasn't the outcome that she wanted. And now that's a little different, right, with those kids with private insurance, because they more or less can do that. But again, everything's a process, right? And it all kind of is with the mindset of showing step by step that this kid is really actually truly needing such a restrictive and such a higher level of care. So the application process, kind of like a little bit, Lyanna kind of touched on it a little bit, but the application process, and I see there are some targeted case managers in the call, so bless you, because I know that this is not an easy process. There are many, many, many steps, many, many, many documents that you have to obtain, and you have to help the family obtain, as well as kind of giving the family homework. Like the first, they need a written, signed letter from either a licensed psychologist or a psychiatrist recommending SIP, recommending residential placement. It must be in writing, it must be signed, and it must not be older than 6 months old. If it's older than 6 months, they need to go get a new one. The second part is obtaining those clinical records. Getting medical records sometimes from, psych facilities or outpatient facilities. Sometimes that can be a bit like banging your head against a wall repeatedly. It can get really, really frustrating. Getting the families to sign the releases of information, all of those things. Those are all pieces of the puzzle that all need to come together and align perfectly for us to get those documentation pieces that we need for the clinical portion of it, right? Because when we send it out to DCF is looking for very specific things, right? I'm sure you guys have all heard about buzzwords, right? They're looking for those buzzwords. They're looking for those, the treatments that this person has been in that kind of pop out to them that say, okay, yeah, they have tried just about everything. So they really need the outpatient treatment. Psychological evaluations, with a full-scale IQ. Full-scale IQ in terms of SIPs, they won't take kids with a certain, below a certain IQ. So having that documented. Medication management notes to show, that they've failed on X, Y, and Z medications, or that they've been seeing a psychiatrist for, 3 years and things just haven't gotten better. It's been medication, as we all know, sometimes can just be trial and error, right? Maybe these things haven't been working. Baker Act hospitalization reports, because we all know, again, right, that not every inpatient psychiatric hospitalization is a Baker Act, right? So that goes for the voluntary admissions too. And then any information that might be critical in terms of previous residential, previous respite. Maybe they were in an intensive outpatient program. Maybe they participated in a partial hospitalization program. Those are all documentation that, that they're looking for and they're needing for the actual SIP application. And mind you, again, that's just the application portion. That's not even, at this point, it hasn't even gotten to the desk of anybody at the managing entity or to DCF. This is just all just kind of collecting those records. Again,
the other part, the medical portion of it and the school reports, and as Emily was saying, like, it hasn't gotten there yet, and that whole process is it's lengthy. So if one document missing is one document that the application can be denied. And I think that's also an important caveat to this, is making sure that with the SIP application, the medical records, including the dental, which is also an important part of it, because again, if the client has some needs on regards of eyeglasses, eye doctor, dental records, or they have specific dietary restrictions. All that information is needed in the facility, so the providers are within that facility know the ins and the outs of this whole person. The birth certificate, social security, information about the school, their grades, where are they in that process. Another part of the SIP application is also that unenrolling the client from their current school to enrolling them, depending on the different residential treatments for SIP. Some do have internal schools, some don't have, and they actually enroll the clients in Florida virtual school. So making sure that those are also additional process that comes in, but still the paper hasn't gotten to the desk of the managing entity. So it's just making sure that we have all the information. The most important also is the physical. It has to be within the past 90 days. And if they haven't had any physicals, that we can make that recommendation, or that the family knows where to reach out to. Sometimes the inpatients, the CSUs do their own physical, and when the client goes into the BACRAC facilities. And that's where more often now we get the most recent physical for the clients that we serve, just because again, most of the clients that we send to SIP placements are in that recurrency of having more than 2, 3, 4 bake racks within a month. And then again, as Emily was saying, the release of information. I think this is the hunting kind of moment with the families and signing a lot of additional release of information, because we might have some in our intake paperwork. However, there might be a new involvement with DCF. There might be a new involvement with EJJ. If we don't know and we don't have that information, we cannot provide that additional information to the different SIP placements. So it's important to have all those releases of information, and even like to get a birth certificate or social security card, like that's gonna take time as well. Like understanding that the collaboration with the managing entity and the family, and again, it's very taxing. So making sure that in the also processes that we're providing additional support to the family, some respite to the family, some advocacy for them to take care of themselves, because it is a lot. It is a lot. I would say 2 weeks ago, I was working with one of the case managers on one of the SIP applications, and like scanning all the information or even printing out and putting things in the system, it's tedious in itself. So it's a lot of paper. Sometimes we have clients that have binders and binders of documentation, of clinical documentation. So again, it's a tedious process, but it is a process nevertheless that needs to happen to make sure that when a client goes into a SIP placement, that placement knows for sure what is the ins and the outs. If they might not be able to cater a client, and they might not be able to do something special, individualized for someone that they may need it in that space.
Yeah, I think it's also, important to note too that, part of the process, it's a process for a reason, right? Because during the SIP application, while we're getting all of these documentations and, the case managers are running around, the families are running around, number one, the SIP application itself comes with its own releases of information that are required. So, organization specific, you may have, releases of information for this kid up the wazoo, right? Sure, you're welcome to send those, but SIP is actually, they have their own, DCF has their own releases of information that are needing to be signed. Also, the part of the process in nature of a true process is that we're still providing services to those kids. And we recently, actually today, we had a kid for the first time in a very, very long time, probably over a year, had a kid go to SIP. She was transported there this morning. But this is an application that, she lives with her grandparents, and the grandparents have been going off and on. They want the SIP, they don't want SIP. She's been doing better for this weekend. Well, now she needs it. And that's kind of also part for the course of the process. Because once the process is started, sure, the family can, has that time to say, yes, for sure, we want this, or no, we don't. But it also gives the kid an extra opportunity, like, hey, this is what we're working on. It's really, you're driving the bus here, help us steer the bus. Tell us, prove to us, right, that this isn't something that's needed. So it really kind of, I, in part, think that it was designed, to be such a grueling process. Again, just to make sure that this is where that kid needs to be. These are the services that this kid needs. So we talked a little bit about this, but how does the CAT team support and continue this collaboration, right? We talk about collaboration so much that when a kid is in SIP, like I already said, they stay on our census. We don't discharge. Perhaps we are providing, evidence-based practices with the family. Perhaps it's just the case manager monitoring their food insecurities. Just as long as they know, right, that we're there, we're here to support, we're not going anywhere. And even if there's a change in the kid's therapist, that therapist is going to pick up and start going to those treatment team meetings in SIP so that kid can start understanding, like, okay, like, I understand that Miss Jessica isn't going to be my therapist anymore, but Miss Veronica seems pretty nice, she keeps kind of coming to these meetings, maybe she does care.
So the other part of that is like when Emily was talking about that continue ongoing services with the family, meaning the caregivers, meaning additional families are involved in the whole process of it, and that goes into making sure case management needs are met as well as parenting. I think once the kids are into the SIP placement, it makes it a little bit easier for the parents to kind of engage a little bit more on parenting sessions and making sure that they're building the skills for when the kid comes back in a different environment where it's easier for them to actually collaborate with the therapist, with the case manager, with the parent coach, and actually practice and coach. And I think when it comes to that, it's that reintegration back and thinking that the client is going to be in the residential, however, the kid is going to come back eventually into my home. How me as a parent, how me as a caregiver, am I going to receive that person? How am I going to receive my kid back into my home? And how I can provide that support, that advocacy that the client needs, that well needed round coaching that I can have for parenting. And that's where most of that services are geared towards as the client is into residential treatment. So that's why we don't close it out. We make sure that we are fully supporting that family as the kid is in the residential. They do additional services in residential, as probably you guys all know, like the individual counseling. They sometimes do family counseling. They do groups. They do their schools. They do a lot of things within the residential treatment facilities. And as the family is in the home, they're often and not left with nothing if we don't provide those services. So it's making sure that they also have those additional services, and that once they're in that process of the aftercare, like at least the residential, the SIP placements let us know at least 30 days in advance. Hey, just so you know, so and so is getting discharged this date, and now we are aware. Now we have a time frame. Now, if anything is a loose end or is to become a loose end, we work with the family closely to make sure that it doesn't become a barrier in treatment as they're stepping down from a SIP placement. Not to say that that client might not need still intensive services like that. SIP placement is not an equitable way of saying, yeah, the client's okay now, fully, completely, no more intensive services forever. That's not to say that. It's more so to say, okay, whatever's needed, so when the client comes back into the setting, that they're able to manage it and being able to be sustainable in that process. And once we're involving the families, that we already have a time frame, not just from the step down from the SIP, but also from the CAT team. Like we have a time frame of like, okay, 90 days, we're going to reevaluate where we at. Do we need to step down by that time frame? Do we need a little bit more? Whatever that's needed in that moment, but that we're also in that thought of, transition and discharging the client into a lower level of care, transitioning them into what they need. Nobody likes to be in a space where they don't see the light at the end of the tunnel. And that the only light at the end of the tunnel might be just residential or inpatient treatment for the remainder of my life. And some clients might need it for that time frame. However, most clients will definitely benefit for maybe different type of pathways, and understanding like the light at the end of the tunnel might be different. And just showing it and being able to hold their hands and show them and once they get there, being able to tell them, see all the things that you built so far. See, it brings me back to Dr. Seuss, all the things that you do. That book, that lovely book, I adore it. See,
Yeah, I think it's super important, because when a kid does go to SIP, it really gives us the opportunity to try to help and, change the environment, as much as we can, by like we're just talking about, by providing that support, by that coaching. Maybe this might open a caregiver's eyes to, wow, I didn't know that X, Y, and Z was occurring right under my nose. Maybe I need help. It's kind of like an opportunity for everybody. It's like a much longer term respite. It gives folks that time apart, to really hopefully, and through our support, look intrinsically, look at themselves, look at their system, look at what is this kid learning and how are they learning it. Is it strictly environmental? I mean, I think everybody in this room knows that that's probably not it, right? It's multifaceted. It's coming from a lot of different places. But also, reminding those parents, like, hey, or those caregivers, hey, you are their biggest educator. You are their biggest educator, right? So just kind of using that time to allow those families to pause for a minute and to try to reset and try to do something for themselves that's going to benefit their families. And that's kind of, again, going back to the wraparound model, that is so significant in the work that we do. So a little bit about, we've talked a little bit about this, but in terms of those kids who are needing residential placement, and they're not Medicaid funded, so the SIP is not an option for them. Again, we are identifying that need. We are looking at all of the avenues that have been exhausted, whether it's traditional outpatient, whether it's several inpatients, and like my next bullet point says, failures at lower levels of care. CAT teen technically is a lower level of care. So once all of that has been determined, like, yes, this kid does need residential care, we are going to then conduct kind of a safety and security needs assessment. Could this kid be safe and function well within the parameters of a locked facility or unlocked facility? What's going to keep them safe, right? What is going to serve them in the best way? I can tell you, like, right now, we're dealing with this on my team personally. I think I mentioned earlier that there was a child who last month was in the community only like 5 or 6 days of the month. That's this kiddo. Unfortunately, right now, he is spending a lot of time inpatient. But also, depending on who you ask, unfortunately, he is also not Medicaid funded. So he automatically, right off the rip, is not going to meet criteria for SIP. But again, conducting our safety and security needs assessments, we have determined that beyond a shadow of a doubt, this kid needs a lockdown facility. So now we're working with a SIP provider, a SIP facility, to see if we can kind of create something called a single case agreement. Is this someone that they could take on, kind of with the promise that, this kid's not just going to be here for 2 weeks. So it's really about identifying those needs and advocating. Advocating is so, so important. So yes, again, like going back through this, we have to identify who can take this kid with commercial insurance, because I'll tell you what, something that I learned very recently was that not all residential placements will take commercial insurance. I'm going to say that again for the people in the back. Not all residential services and residential programs will accept commercial insurance. So really kind of doing your due diligence, doing the legwork and helping that family out. Who does take commercial insurance? Okay, great. Sandy Pines does. Fantastic. How long is their wait? What are the considerations for a child who is not going through those multi-layers of a managing entity, of DCF, all of these things, right? What are the considerations? How do we get admitted? What's the treatment process going to look like? Is it going to be different because technically it's not SIP? Do they need supporting documents? Do they need all of those same, or an abridged version of what we submit for SIP placement? And again, at this point, with a commercial residential hospitalization for a family, it's their choice if they want to discharge or if they want to stay on the team while the kid is in residential placement. Is there anything you wanted to add, Lyanna? Sorry.
Not necessarily. I think it's because most of often and not. I think that part of the non like the commercial insurance of residentials, not all residentials being able to take that type of insurance. Sometimes there's even options outside of state, but again, it's also at the discretion of the family if they want to do residential treatment outside the state. Those are brought to the attention, especially on the local review teams. We do, speak on behalf of the different type of modalities that they might be available. It might not be in the state, might be outside the state. They might be looking for something more specialized, and they don't have it, and we don't have it in the state of Florida, and they might have it in the state of Georgia. So something like some situations and instances like that we're exploring and we're navigating with them. What is the best option, and how that is going to look for them? Some families might not have the accessibility to even have a residential treatment, or might not be able to with their commercial insurance to pay for that services. And what else is available there so they can actually have that service, or at least a somewhat similar service for themselves.
Yeah, thank you for saying that. Also, like, we're always wanting to be the step down, so again, like, if they do decide, okay, well, they're discharged or they're in residential, we don't need the CAT team anymore. Okay, well, keep my information. So when, Patty Sue comes home from, anywhere, other residentials, let's say Lotus, that you guys have our contact information. So if things are starting to get dicey, or perhaps because it's commercial insurance, perhaps they're getting discharged sooner than you anticipated, we're always ready and willing to bring those kids back onto the team, because we recognize that need for comprehensive and intensive services, to again reassimilate, to get back into the community, to find their groove again within the home environment. All right, moving on to Baker Acts and ex partes. And so you guys see how big Lyanna's smiling. She loves to talk about Baker Acts and ex partes.
Yeah, you say that, and that's one of my things that I try my best to avoid, because I know that sometimes it's difficult for families, especially bake cracks and ex partes. Especially, and this is just, again, it's a quick snip of what those are, not necessarily what they're fully are in comprehension. But the bake cracks sometimes are initiated by our mobile response teams throughout the whole counties. So not just our counties, but the counties around the whole state that have different mobile response teams that do attend to those, and they're actually initiated by them or the officers. And I think that's where I smile, because sometimes most of these bake cracks are initiated by officers, and families have a certain perception about how these are initiated, how are these established, and but again, it's about educating the families about what a bake crack facility is. And I think when I shift most of the idea that this is like going to an emergency room, rather than seeing it as, oh yes, this is a kid getting arrested and going into a facility locked for 72 hours hold, it shifted the idea to some families to understand, like, this is a necessity for the mental health. Like whenever you have a super chronic condition and you need to go to the emergency room, the same thing equitable to what your mental health you're going and the struggles that you're currently going. So it's making sure when we're working on with these big cracks, as we're collaborating with them, is making sure that upon discharge, trying our best and doing the legwork to ensure that we get the clinical records. Because again, they come discharging from a Baker facility, and they come with medications, they come with treatments, they come with something, and knowing what they worked in there and what they have utilized within that space is good for us to know as to step down from that services. Also, if we're working to a SIP application, it helps also the SIP application know what they've done so far and how many of these CSU visits the client actually had. The other part is doing visitation. I can tell you the amount of times I've been to CFBH, UBC, where the client knows, oh, yeah, you're my therapist that's going to see me right after this, or after I come out of the Bake Rack facility. It's not just a one way, oh, yeah, you're going in there, you're not going to know that I'm there. Just a month ago, I had a client that was Baker acted, and she was in one of our facilities, and I gave her a call, and she was surprised that I gave her a call, and she was like, "Oh my God, thank you for calling me." And then the next week, it was a little bit more stable to manage her symptoms in the community because she knew who I was, she knew the team. So when she was stepping down out of the Baker facility, she already knew that she was going to have at least one familiar face from the team receiving her back into the community. Um, Baker acts, I don't see them as a punishment or as a way off. Some clients do, and I try to minimize stigmatization about it and make sure that they're aware that this is just a service, just like any other service. That sometimes we need it, and sometimes not knowing what the caveats of that is, because again, it's scary to be locked in a space in an inpatient unit. It's scary as a child. As an adult, imagine as a child, and for families that might come from another state, come here to this state that we utilize this type of strategies, might not be accustomed to this process. And we're in Central Florida here in this area, and we are majorly a city. But let's say a client is in Ocala or somewhere that is more in the outskirts, and they might not be familiarized with this type of modalities, and they go into these settings, and they were like out in the community just a few days ago. They got arrested, or a mobile response team came in, and they immediately got into a Baker Act facility. So it is a scary. So I try to work with families to understand what this is and what is not, and why is it needed and why is it not needed. And just being there and providing that information kind of alleviates the process of, oh my God, I'm sending my kid to a space that they just going to be there locked in and nobody's going to do nothing for them, and they're going to be discharged in 72 hours. I think that's the one thing that resonates a lot when I have clients that do go into a big crack. It's like, oh, they didn't do anything. They just hold them for 72 hours. And just like an emergency room, they might not do a full comprehensive full treatment, but they might stabilize you in a space like that. And that's what the intention for a big crack is, to make sure that you are stabilized rather than fully fully cured, to say, not to say that, that you're fully in a space that you are not suicidal, that you're not homicidal, or that you're intentionally trying to hurt yourself or hurt someone else, or get into a situation where it's high risk for you. So Baycraft, again, for me, they have a special need in my heart, because I know that sometimes families need it, but they run away from the idea to even think about getting their kids into a space like that, out of fear, out of not understanding, which is really understandable. But again, it's a big part of, like, hey, educating them. Hey, this is where, if your kid went here, here's what you call. Here's how to proceed with that. Make sure that you're in constant communication with them. Make sure that you ask questions, that you know what the ins and the outs of that is. Once your kid gets discharged, let us know. Let them know that they're participating with us, as well as if they came out with medication or with treatment or recommendations, to ask questions about those and what those means for you as you're stepping down, or provide some psychoeducation as you come out. But let's say you're there with the psychiatrist, you're there with the medical provider, you're there with a therapist. Ask those lovely questions so you know as you're stepping down. So for us in the CAT team, we try to increase our services to 2 to 4 times a week instead of just one time a week, which is a traditional. However, we do increase those, especially if we're in the instances of discharging. For example, we're not going to discharge a client within that month. That changes our discharge process as well. So it's making sure that if we get a client and they're at the end of their services with a CAT team, and they're about to step down, but they get Baker acted, they're not going to get, they're possibly not going to get discharged from the CAT team. They're going to continue services with the CAT team, just because we know and understand, like, after 30 days within those 30 days after your discharge, there's a higher incidency of getting into a re-engagement with the Baker Act. So we want to make sure that those are managed before you go into maybe a lower level of care, or that you are working with another provider, and that at the same time you're stable enough to maintain your sustainability. And again, if you need a Baker Act, I think Baker Act is not a determination for many things. Is if the family is utilizing it in a proper manner and they understand the meaning of how to utilize it. Because I think, again, like going with a chronic condition, you go to the ER. Same thing for this. You might need it once a year. You might need it maybe once every 5 years, and that's okay. And minimizing the stigma that oh, Baker Act's equivalent to not being mentally stable. It's, it's a bias that we and society kind of sees as. So minimizing that stigma with the families and educating them, hey, that might be something that you might need. Here's the resource. Here's where you can go. Here's, if you want to go into in a voluntary Baker Act, you can always go. There's different levels of a Baker Act, not just the traditional involuntary Baker Act. There's also the voluntary Baker Acts that you can attend to and you can actually access. So those are some of the resources for the Baker Act. And again, it's educating. The more we educate the family, the more we collaborate with the providers from the different facilities, the more successful and the better outcomes the clients can actually receive. Again, it's in a continuum of care. It's not just a one-way route. Sometimes the route looks like this. So it's making sure that we're working with them in those whole roller coasters of their own pathway.
Yeah, and we emphasize so much the collaboration, and sometimes, there are, and as I'm sure in whatever counties you guys are in, we all know that, people from lots of different countries come to Florida. Florida is, home of Mickey Mouse and beautiful beaches and all of those kinds of things. And so sometimes the families need a little bit of extra hand holding, understanding the process. What do you mean my kid has to go to a hospital? Like, what are you talking about? Also, what we run into a lot too is, the religious beliefs of family members. That they, God is going to protect them, or their higher power is going to protect them, and doesn't believe that they need to be hospitalized, and kind of, being really, really sensitive and cultural, providing that culturally competent collaborative care. That this is not a reflection on those things. Also, it's equally important, in my opinion, to also have that collaborative relationship with those inpatient facilities. I feel like I have been lucky enough to been able to have and developed these really good relationships with those providers, and so there's kind of maybe a little less red tape that we have to go through. Of course, again, absolutely adhering to, releases of information and, doing all of those things the appropriate way and the ethical way. But there's also a little bit more ease, right? There's a little bit more comfort, because chances are this isn't the first kid that you and I have collaborated on over at, such and such facility. So just again, in the spirit of collaboration, it's not just one-sided on the family or caregiver's end, right? It's also pulling from the other side of things, to say, hey, with the facility, hey, yeah, they see our doctor. Or yeah, you got it. I have people emailing me all the time, like, hey, this mutual client is here. Can we get them scheduled for, a medication appointment? Yes, absolutely. Let's do that. And then our team will schedule it. And then we reach out to the family and say, hey, we're working on this with such and such facility. And it makes things less stressful in an already really super high stress experience and environment with those families.
So
similarly, when we're looking at,
sorry.
What's that? No, that's
So
okay.
the other aspect of working with the expertise, I think that's where we're segueing now into the expertise and juvenile detention and drug court and teen court. I think it's ensuring that we build this strong relationship with our community partners, our JPOs, especially with our JPOs and our core providers and our core staffing, that we can share and we can actually have information between each other. Again, clients are engaging in these systems, are higher risk of re-engaging in certain instances. So it's making sure that this collaboration with these spaces are as high as that. Again, at least I would say, I tell my team, at least on a minimum of a monthly basis, please coordinate, speak with your JPO, speak with the court, send them a report, making sure that the family knows what we're sharing with the courts. I mean, most of the time it's just, most of the time is like, how many sessions have you attended? How many, if there's a mandation for a drug screening, how many drug screenings have you participated with us? How many family therapy sessions? How many mid-management or case management sessions have you attended? And in that collaboration is again, feedback between all of us and having conversation and consultation of what's the best for the family and how to make sure that if these families are court involved, that they know the whole process and they are connected with the resources they need. Most often than not with teen court, I think which is a special thing in my heart with teen court is that if a kid is involved in teen court, their court gets fully expunged, and that by the time they're 18, that case is no longer there for them. And I think that's where I feel like when we're working with the families that are working with teen court, that they are engaging with whatever they're mandating them or that they have to complete within that space. With drug court, is with the families a little bit more involvement, and there has to be some level of drug screenings, and that's a lot more involvement because there's all those systems that do are involved in that process, like DCF and the different lead agencies that work with DCF for the department, with the DCMs and their the department case management that are working with them, the defense case managers as well. So in this whole scenario, when we're working with juvenile detention, drug court, teen court, we're seeing a system that is complex enough and that we're collaborating with all the parties. I think collaboration is the biggest key because each of us speak a different language, and I think that's something that as we were for this whole past year, we've been engaging a little bit more with the courts and the DCF and the DCMs. And in that whole process, each one of us speak in a different language. We in the clinical setting speak differently than the courts, than the DCMs, than the case managers for the court or the liaisons from the court. Like everybody speaks a different language, but making sure that we're in the same table, even the families tend to speak a different language. So when we're in the same conversation, that we all understand what we're there for. And I think the most important is always making sure that the focus of is making sure the client doesn't have a reinsertion into the system, that they can actually prevent it and they know the skills and the resources available for them so they don't have to re-engage in the systems.
Yeah, again, just the building those strong relationships, I just cannot emphasize the spirit of collaboration enough. And it kind of in doing so, we are also able to kind of successfully serve as that liaison, right, between the courts and between the family. We have a client right now who keeps getting arrested, and now he is currently in a 21-day hold at the juvenile detention center, and his father doesn't understand. His father, unfortunately, never learned how to read and write. So, you go to a court hearing and they're throwing around all these acronyms and all of these words and sanctions and, anybody. I mean, it's hard to understand. It's hard for me to understand. I have to see those things in writing before I can conceptualize them, and so just again collaborating, serving as that liaison is so important, and it's really invaluable to those families, because they can understand what the expectations are, right, and they can help manage and mitigate those expectations, but also providing that support to not only the family but to the kid, normalizing those reactions of fear and guilt and overall fatigue and anger and, confusion, all of those things. Those are all completely normal emotional responses to being involved with drug court, with teen court, kind of as we've been kind of saying this whole time, and as Lyanna was saying too, providing that psychoeducation to the caregivers on delinquency. What does that look like? What to look for? Recently we're running into, more and more of our clients coming into us with potential gang involvement. Providing that psychoeducation to the caregivers, to families on what those things actually look like, what might they see, and what might they be able to stop, or what services can we help them identify and put into place that can minimize those things, right? Because we all know the rate of recidivism is much higher than it needs to be. But also, safety planning, a huge part of what we do on an ongoing basis. And I thinking back now, I apologize for not mentioning this during our conversation about Baker acting, but Safety planning is so critical to what we do. Sometimes if you look in our charts, one kid might have, 9 different safety plans, because again, assessment is ongoing. Those things are always changing. Support people could be changing for that client. But again, all gearing towards making them feel supported, making them, helping them understand, what's playing out kind of in live time in front of them.
So the other part is, with drug quarantine court, sometimes they do get into a higher level of care within that space in the system, which is the juvenile detention center or the JAC. They do get into space where now they need maybe assistance with the school, because again, once they're in a setting where they're restricted to be outside in the community, they might need re-enrollment into the schools, or another pathway to schools, because again, it's not, education is not just a one way. I think education is in many ways. Some clients might need maybe a GED once they come out of that system. Maybe they might just need an alternative school. They might need something different that might cater to their educational needs rather than the traditional school systems that we have. Not saying that might not be sufficient, or it might not be intramural as we're working maybe other alternatives. Again, school is for some people, not for everybody. And as we're working with that, I think advocating and supporting and psychoeducating the family, what that's going to look like for them, might be a little bit different. Advocate, as it says there, making sure that we identify our clinical needs and our educational needs, because again, these are the ones that are protective factors that could prevent clients from re-engaging in these systems. What they don't know, the families don't know, especially with the gang involvement. Like, they might not know everything. Even with substance use, I had a family that the family thought that what the client had was a pen, like an actual writing pen, and it was not a writing pen. It was a vape pen, and within that space, within the vape pen, they had marijuana, and the family didn't know, because again, they were not exposed prior to these situations. While when the client came into teen court, now they know that was something that the client was engaging into. And psychoeducating the family in all aspects, meaning, sometimes there's marks, sometimes there is instances, there's times of the days, there's things that they haven't handled, the way that they handle their social media as well, is something important when we're talking about these instances with teen court, the juvenile detention centers. Again, there's many things socially, and with advancing things we're having nowadays, if we don't educate the families to what these look like, they might not know everything. And that's very important, not just the family, but also the kids. Sometimes even the kids don't even know that they're maybe part of a human trafficking gang, and they don't know about it because they're just engaged in that because they wanted to be part of something, and now they're involved in this whole situation, but they didn't know. It's educating all across, and above and sideways, maintaining that involvement post release. And even when they finish teen court, that doesn't mean we're gonna discharge a client. And I say teen court because that's what we have here in our central area and in our counties. I know some other counties might or might not have teen courts, or other states might or might not have teen courts, but understanding, like, we're still gonna have that involvement even post release of that process. That once those sanctions or whatever they have to do within that space are completed, we're still going to maintain the services for the client until they maintain a sustainability within their space, and monitor their engagement with the services and adjust as needed. With court involvement, sometimes the families don't want to be in services, and they just feel the pressure from the system that they have to be involved in services. And making sure that they understand why, and also that they have a choice within that space. Although sometimes it's the pressure of being in the system to not be in the system that maintains them and motivates them to be in the services that we're providing. Again, showing the light at the end of the tunnel. I think once they identify and they see that light at the end of the tunnel, it makes it easier for them to know, okay, I hear you, I'll try my best, and I'm gonna be here, and I'm gonna be willing, I'm gonna participate the best I can, and just adjusting as best as we can. Sometimes family wants to meet us in the office, perfect. Sometimes they want to meet us at the park, perfect. We'll meet them where they at, so they don't feel the pressures, because they're already experiencing a lot of pressures from the court and the juvenile system itself. So it's making sure that they're advocated and that they're supported within the space of that. Because again, it's a lot of things. Even just yesterday, I had a session with one of my clients, and they're like, "Yeah, I was following I was reviewing what you told me how it needed to go to team core, and I dressed properly. I put a tie, I put my
Mhm.
shoes, and then I was there, and I answered all the questions as we did in the role play, and like, yes, those little things. Because even then, when you go to the courthouse or you go to the magistrate, you're like, oh wait, there's more rules here that I had to follow to make sure that I am in compliance with my case or in compliance with what I'm being told to complete or being informed that I have to complete within that space. And there's things that we don't all know. I mean, I didn't know I could carry my key cards. I had to put them outside, and I couldn't bring them into the courthouse sometimes. So, those little things that we might not know fully and understand fully, the families not I might not know them as well because that might be their first time involved in these systems. And again, being supportive and being advocating for them and being there for them. And I think something to add to this is sometimes mentors go to these hearings with them and case managers go with them into these settings to provide support and being able to be there, not fully involved, but at least in that space providing that additional support to that family.
Yeah, yeah, absolutely. And Megan, to answer your question, she asked, does your JDC allow members of the CAD team to see the youth, or do they restrict the therapist due to potential duplication of services? So on our teams, we definitely allow our therapists and our case managers to go and visit, both either while they're in juvenile detention or while they're in a Baker Act, if it were, it's turned into a longer than 72-hour stay. But yes, we are very careful to not provide therapeutic services within those environments. We are there just to be a support, just to be, like I've said a couple of times, just to be that friendly face to let them know that, like, hey, we're in this with you. We are invested in this in a way that is a support to you, right? So we're not going to, get into therapeutic modalities or treatment assignments or things like that when they are within those systems. But we do want them to know, like, that we are here. We are here. We are rooting for you. We are on your side. And we're going to kind of help through this process, whether it's helping figure out next steps or just helping hold your hand through the process, because the process is not great, right?
Mhm. And making sure that we have a release of information. I think that's the other caveat to that is like not just saying yes, we can go in there to provide some support, but that we also have that release of information, that authorization from the caregiver that we are allowed to, but also if the other entity also has their own release of information, that we also are completing those as well. Because if, for example, we have to do visitations to a certain organization and they have their own specific release of information, that we're listed in that, not just a one way. It's the both ways communication, not just one way.
Yep. All
Alrighty.
right.
So, see, this is the area that I think very important to know, and I will stress this one out a lot. Shelter orders are important. If there is a custody process or anything of the sort, we need information as much as possible. We work with, again, clients that are involved in child welfare. That doesn't take away some of the services that we provide. However, not having all the information needed to be able to provide services or not having a space where the client is going to be stable on a long term makes it a little bit more on the difficult side. Again, seeing a therapist today in Orlando and then tomorrow something happened and now I have to move to Panama City, then so it's shift in environment, and then the environment itself might be the indicator of why we're having some behavioral or mental health struggles. But at the same time, we're going to provide that immediate crisis response and stabilization, provide that emotional support to the children and the caregiver. This caregiver might not be even the legal guard, the biological caregiver of this person. In that sense, this person just kind of inherited this kind to themselves, and now they're taking care of them. So providing that support, that information, that certification, that full advocacy, so they understand, like, these are some situations, some things to look for while we're working with you, providing that additional support. Right now, we have in one of my programs, we're working with some foster parents. This is their first time engaging in mental health with any of the kids that they have involved themselves as foster parents. So they are fairly new into this information, so they don't know how to navigate it. And they've been foster parents for the past 15 years, and they just don't know how to navigate it. They're just trying their best with the information, the little information they get from their classes to be foster parents. But again, one thing is one class, one thing is actually living in a day to day. Clear communication and system navigation. I think with the DCF, again, as I was talking earlier, we all speak a different language, but coming into the same table, having the same conversation, modifying some of the language and talking with each other and kind of like explaining what I meant or what the other party meant or what the other organization meant with certain information. For example, we call it here as assessment. So we do in-depth assessment by psychosocial, where sometimes I have DCMs asking me for a substance use evaluation or a mental health evaluation, which the college is a little bit different, but again, it's coming to the table and being open to hear and understand, like, we do speak the same different language, but our mindset is set to the goal of supporting the family in the whole process, and not just the family, but also engaging them. And I think taking away the family and the client from this process is, it's a deterrent to the process itself. So when we're talking and we're working with families that are child welfare involved, everybody talks and everybody has to be in communication, open communication, and not hiding things from each other. And everything has to be a little bit more on the open, obviously with our correct release of information and everybody hitting the same page. Again, this is for the benefit of the family and understanding what is my role, what is the role of DCI, what is the role of child welfare, what is the role of the family in itself. And everybody is in this whole system where we're all communicating, and there's not a secret that is not shared, because again, it's for the benefit of the family and for the stability of the family in itself. I want to be open about what we're working in the family. Sometimes the families might be, I don't want to talk about that, but that's something I may, and giving them the space that they need in the moment. At the same time, understanding, like, if we're gonna collaborate, we collaborate with in openness and willingness. Because if not, then sometimes more often than not, that the progress might not be achieved.
Yes. Again, we're always wanting to provide that psychoeducation on potential trauma based on removal. That is never, for anybody who has been through that, either with themselves or with a family member or a client, we know that can be really awful. That can be a really awful, traumatic situation to kind of go through. So providing that psychoeducation on the trauma, providing that psychoeducation on the potential trauma of that removal. Always, we're conducting safety planning. We are always safety planning. Even if it's not a formal safety planning, we're always talking about it. We're always talking about next steps. Also, in the spirit of collaboration, we want to be in contact with those DCF workers. We want everybody to know who we are, whoever they are living with, whoever the kids are living with temporarily, in the event that they do get removed. We want that person to know, hey, we're involved, we are supporting, we want to set everybody up for the highest chance of success, right? And we're always advocating, always, we're advocating for that kiddo, right? So many times, as you guys all know, right, the kids' voices get lost, and we are here to help make them heard, and feel seen. And then, of course, as the case wears on, we do provide support with the transition planning and, excuse me, gearing families and caregivers and those supportive systems up for the upcoming transitions and what those might look like, and just continuing that handholding, continuing that walk with them, because they're not alone, they're not by themselves. And then the same kind of rings true in terms of family dependency. When DCF is involved there, we are always wanting families engaged, right? I think that's one of the first things that I said, that family engagement is crucial. That does not stop just because they are maybe not living with their family of origin, or whoever has been their primary caregiver. That family engagement, that relationship building, those things never end. As Many people, in the call, we have family members. Maybe you have children. Maybe you have nieces and nephews. That engagement and that relationship building with them never stops. And it's even more critical in these moments because when somebody is removed from the home, that's traumatic for everybody. So keeping a finger on the pulse of how is the family doing, right? The kid is our client, yes, but also how is their primary caregiver doing? What's that relationship like? How do they need support? Do they need extra counseling? Those sorts of things. Of course, in hand holding, we're explaining hearings. Lyanna was saying about, everybody kind of speaks in different lingo, right? So helping to identify that, okay, what's on your case plan actually means this. When the attorneys or the judge is saying X, Y, and Z, this is what they're actually meaning. Just kind of breaking things down, not because they're stupid, not because they don't have enough brain power to understand, but because it's difficult. It's difficult to navigate the process. It's emotional to navigate the process. And things go in one ear and out the other. Even you can be the smartest person on the planet. And in those moments where tensions are high, emotions are high, you could forget that you were at the courthouse this morning. So being there to support, to explain, again, to handhold. And with all of that, I think naturally comes the emotional support, as well as ensuring that emotional stabilization, not only of the child but of the caregiver. If a caregiver is feeling like they're going to harm themselves because their child just got taken away, let's talk about that. Let's give them that support. Let's be, like the slide deck says, let's be a safe place for not only that child but for their families, for the caregiver, for the new caregiver, from start to finish. Because when a kid is involved like that, the CAT team doesn't step back. We're not shying away. We're not passing the buck. We are there. We are running that race with them.
And one of the last things is on, when we're working on family dependency is parenting coaching, barrier reductions. Again, it's making sure that the family knows, because again, the case plan sometimes is so dense, and the families that themselves might not know, or the foster families even might not know all the caveats that come from that, and how to reduce those barriers so we can achieve those goals within those case plans and those different demands from the different systems. Could come from court, could come from the DCF. So making sure that they know how to reduce those, that they have the skills, that they can increase their parenting, and they're able to reunify with their children back again in their homes. And also, I was thinking as we were talking, some foster parents are in the process of that family dependency, and the biological parents are taking custody back. It's also supporting that foster family, as well as they're also parting ways sometimes, because sometimes the children do get reunified with their biological parents, and making sure that the foster parents are supported in that process, and they understand that that might happen, and if that does happen, these are the resources that they look for. That could be family therapy, that could be counseling therapy, that could be some very different ways of actually supporting family with actual resources and strategies for them. Being consistent with the coordination, communication, and making sure that at least, I would say at a minimum, having staffings with all these other providers on a monthly basis, providing updates. Because again, what's unknown is not workable. If I know something on the treatment side and the DCMs on their sides don't know, or the courts don't know, then it's difficult to understand what's happening, and the communication might be the barrier for the families to achieve their goals from their case plan. Again, the biggest aim is for the stability. Stability cannot happen in a vacuum where there's no communication between parties or different organizations. It's making sure that everybody's in communication and support, having that pulse, checking that pulse, as Emily was talking about. Because again, most of these families do need and need that advocacy for that support.
All right, long awaited break time, everybody. If you guys would like to take maybe like a 10-minute break. or excuse me, a 15-minute break is what I think we allocated. So if you
Yeah.
guys want to meet back here at 3:25, and in the meantime, if you guys want to, I know our goal was to kind of take some questions, but if you want to chat your questions or type your questions in the chat, we can try to respond to those kind of as we're going along. Otherwise, we'll see you guys back at 3:25.
Hello, everybody. Welcome back. Let's start wrapping up and coming back for the portion of the activity.
Sorry, I've been on mute talking to you guys this whole time. Welcome back. Before we jumped into the activity, I just wanted to see if anybody had any additional questions that Lyanna and I could answer before we move on. Anyone? And we'll allow some time kind of at the end as well for some additional questions or comments or insights as well. All right, I'm not seeing anybody with anything new. So just make sure, Reverend Clark, I just wanted to make sure that you did get my response to your question. You asked if I could answer your question from 145, so I just wanted to make sure that my answer was understandable. So if it's not, just flag me down, let me know. All right. Yep, no problem. All right. So moving right along. So we're going to break out into some breakout groups where we're going to kind of just we're going to have you guys spend maybe about 20 minutes or so just kind of developing some strategies for engaging some kids and family into school attendance, community integration, and improving family functions and their symptoms. So I'm sure many of you have heard and seen the kind of PDSA, the Plan, Do, Study, Act, and that kind of model of constructing these ideas in terms of empowerment and treatment and connection collaboration. So Lyanna, do you want to say something about the activity?
Yeah, so something about the activity, because I think we have about 19 people in this webinar workshop that we are currently having. So we're gonna split you guys, I think, from what I see, about 4 groups. Each one of the groups is gonna focus on one of the areas that we were talking about collaboration. So one group, group number one, will be integrating into the academic and school success. Second group will be into the community integration, how to integrate our clients, how to advocate for that, and how to work in that area. Third group will be on the family functioning, and then the fourth group will be focused on the symptomology improvement. So as we're working on this, think about how you, in your programs, in your current roles, in your different areas, will be working and kind of advocating for strategies that could support clients and families in these spaces. So as we're working into it, me and Emily will be jumping into some of the groups if you have any additional questions. Uh, and we're going to be working with you, and we'll come back within the next 15-20 minutes as we're discussing this, and then we'll jump in together. So please select someone from your groups that can speak on behalf of the group that you were assigned to, on what strategies you guys developed. Well, as we're working at this, once you guys join in, we'll talk also more so into the ones that we currently use on our end, and how those relate to the ones that you guys are choosing. Again, we work in the CAT team, so our mentality on the wraparound model might be a little bit different from your different roles that you're currently involving yourself. However, please focus on what in your role or in your communities you can actually work with the families that you're serving and that you're supporting in those spaces. Any questions so far?
Doesn't look like it. Okay. I think Noel, you said I started a little late. It won't count for me. I'm not sure what you mean by it counting. If you wanted to clarify. But otherwise, we can go ahead and break out into those groups. And like Lyanna said, we'll just be kind of popping in and out just to kind of say hey and hear what you guys are working on. Welcome back.
Welcome back.
Sorry about that. I was warned too. All right. Sorry about that. All right. So we thought maybe we would have a little bit of an opportunity for maybe a spokesperson from each group. And I know there were 3 groups. So if there's a spokesperson or somebody who kind of wants to just talk us through, or someone's that want to just kind of talk us through what kind of strategies or engagement opportunities that you guys thought about. And like I told one of the groups, there's no wrong answer. We're all just brainstorming. We're all just doing our best. So should we do school first? Somebody from school want to chat about what you guys were talking about?
This is Robin. Marcia and I were talking about, from the get-go, who's getting the kid ready to go out the door to school? Is somebody there, or is mom out at work at 4 o'clock in the morning and not there to prepare the kid to walk out the door, whether they're taking a bus or whatever? And if there's no food program at the school, or they send the kid out the door with a sandwich. One thing that we talked about was the communication of the agency to the caregiver parents that, look, even though you're involved with services with this agency, it's important that there's that touchstone of school every day, that child knows that this is a constant, and that, getting up out of bed, getting your sandwich or whatever, getting washed, dressed, getting out the door and getting
I think I
it
lost
is a
you there,
touchstone.
Alan. There we go.
We talked kind of about who at school, what teachers at school are going to know the involvement of this child in other services. Of course, if the child has a medical issue, the school nurse needs to know. Let's see, Marcia, what else? Chime in. Maybe she's not hooked up with this.
Yeah. Are you hearing me?
There she
Yeah.
is.
Okay.
There she is.
Yeah.
Yeah, go ahead.
It's trying to let some of the parents. Well, I'm in South Florida, and to having a parent who has to work in the fields from leaving home at 4 o'clock in the morning, and culturally, they have thought, well, okay, I've worked in the fields all my life, and I didn't have a high school education. To try and get them to understand the importance of school, and trying to break that cycle. Sometimes it at least, and to talk to the child also, to let the child understand the importance of an education, and maybe have a relative or somebody in the neighborhood, because they tend to live very close and the neighbors know each other, to have an aunt or a abuela look out, to see to just make sure that the child is up and out and attending school.
Marcia also mentioned that some generations, mom and daddy caregiver, they don't see the power of education because they themselves never finished school.
Right.
So that would be something that comes into it, right, Marcia?
Yeah, and sometimes I've had cases where they have the kids, once they get into high school, they're 15, 16, they're out in the fields.
Yeah.
Because it's easier it's better for them to be making money than going to school.
Mm-hmm.
Yeah.
Yep.
Yeah.
Yeah,
no, and I love that. I love how
you have to sort of have a conversation about the importance of an education. And we also talked about kids who are falling behind. If sometimes there are programs, if you can sort of find a program in school or a teacher who is available to do, maybe stay out an hour or two after school and help, a group, get a group organized that they can help them with homework or understanding a project or some, to get them through that. Because sometimes, usually, um, the parents don't have a grasp on English,
Oh, yeah.
and it's difficult for them to help their child through school.
Mm-hmm.
And
So
I think it's
it's
important. And what I was hearing is like, not just seeing it at the big picture, at the end goal of what we're aiming for academic success, is seeing it from the get go. And I think that's resonated with me a lot when you said like, oh yeah, from the get go, from the time they wake up, they're going to school. Like, how are they gonna get to school? How are they even they're gonna have some meal throughout the day and actually have a meal in the morning time? I think, where it's difficult to function on an empty stomach, and if the kids don't even know if they're going to go to school or have a meal throughout the day, and what resources within the academic setting are. But also resonating to, that limitation of English proficiency that we have with some families that move from other countries, from other states, and they come here
yeah,
and they prefer their kids to be in the working field rather than in the academic field, and seeing the importance and leveraging with them what would be the most beneficial for them, and what is the, how can we support them in that process. Because across the board, like academic success for me, I don't see it as school success. I see it more so as academic, like what is the clear
yeah,
needs at an academic level. That might be just a GED, that might be a sponsorship, that might be something so different for each person as we're navigating academic success. um but also that's so important, like from the get-go, not just from, oh yeah, the client's sitting at the client is sitting in the classroom and now we're thinking about academic success. Oh, the kid has an exam next week and now we're thinking about academic success. No, it's thinking from the get-go, from the home, from when once the client wakes up and is getting ready to go to this setting. So I think that's super 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 important as we're working into that, and also teaching the families, like, what that looks like for your kid. Because some families are also, hard on their kids on academic success, and they had to have, A and B grades in the school setting, and that's non-negotiable. Or they had to attend, they had to be on these 100 programs within the school setting. But also something that, as we're talking about the food itself, like summertime is a realistic time for a lot of families, and most of these families actually get their eating and breakfast and lunch from the schools. What other resources the schools can provide for these families that there might not have money or resources for feeding and food security after school and during the breaks throughout the year? I know some schools do provide like boxes for their families, and in discretion, they provide those to the families that are in need of maybe some foods and some areas, so they can actually make their own foods within their home in discretion to the families. But again, it's helping, sometimes holding the family's hand and the client's hand to like, hey, these are resources, to access for yourself and to be able to be successful within this space. I had a client that didn't want to go to school. They just wanted to be a tattoo artist. Fantastic. How can we bridge the gap with the parent that was so against the tattoo artisting, and being and the client's goal to be a tattoo artist, like, and it comes with the cultural aspects, come with so many things, and how to pivot from one traditional way of seeing academics into a more comprehensive way of seeing academics for an individual, so they can be successful and sustainable even after those settings. Transportation is a huge, huge, huge one as well that resonates to me, just because, I mean, I have so many friends and families that live in Seminole County, and they have struggles with the transportation system there, where if I'm not mistaken, the whole system for bus passes has been declined now. They don't have those services in that area. So some students now have to rely fully on school buses or family members transporting them into the school setting. And, having those natural supports and those additional supports that can actually be beneficial is also one added thing that I can think of.
Yeah, and I
it's
love
educating sometimes the
Marcia. I
parents.
love. Oh, I'm
It's
sorry. What was
educating the
that?
parents of what services are available. Because a lot of the
Yeah, and
parents,
Igor
when they, a
said
lot
that
of
an
the families, when
intervention
they
with the
come here,
guardians.
Mhm.
Igor mentioned a possible intervention with guardians, maybe in order. And so some of the things that we use, we partner with the family, with the school to identify what are those barriers. How can we fix them? Can we help alleviate some of that stuff? Co-creating a step-up attendance plan. Like partial hospital or partial days to slowly working your way up to full days. Is it something that we could even incentivize, right, until it becomes a better experience for them? Is there an ally at school that they can check in every day with, or that can, maybe the ally can go and check in with the kiddo? It may not necessarily need to be a reciprocal relationship. But also tracking that progress visually. We all respond to visual stimulation, right? So whether that's an attendance chart, and that might be a little bit juvenile for, the 10th, 11th, 12th graders, even the 9th graders, but finding something that works, right? Finding something that speaks to them in terms of being able to track their progress. And I think we'd all be really surprised to see how much pride someone, a young person, can take in seeing their progress visually. So yeah. Some other ideas and examples of partnering with the school systems are maybe attending those IEP or those 504 plan meetings, supporting the families through that process. An example of a school ally could be the school social worker, the SAFE coordinator, maybe a friendly teacher or administrator, maybe a coach, and anything of that nature. Excellent. I think this kind of will steamroll right beautifully into the community integration. So is there somebody that wanted to talk to us about what they explored during their conversation with community integration? I heard when I popped in, I heard you guys talking about using a strength-based approach, which I love. And obviously, right, the very first words on the slide are strength-based. Anybody?
Okay, I can, because I did kind of write some stuff down, but I struggle with my volume. Everybody can hear me?
Yeah.
Yes.
Okay, it took me like 5 minutes to find this, or last time. So, interesting, like listening how you guys discussed the first group. The second group that we're part of, we kind of like figured out what all roles we're already currently in. We had a life coach for youth, a youth life coach, a behavioral health consultant, and 3 mobile response teams. So in reality, we're all individuals that are not providing or part of a wraparound service. So it kind of clearly explains like our thought process. Because I'm listening to this, I'm like, oh, we didn't go there. But we talked about like basically empowering the individuals and advocating for their own voices, identifying their strengths, their coping skills, doing warm handoffs. So we didn't really approach it as in the fact that we were going to be doing it with them, because honestly, that's not our everyday role as it is. But we would be identifying where, like pairing and linking. We talked about being aware of their needs and their abilities, and then probably integrate it in the community, because at the library is an option. What are the age brackets for those programs? So can they actually go to it? That's probably something that maybe we would touch on, but not to the level that I heard you guys discussing in the first group.
Yeah,
I have a question. What do you do with a kid, a youth who's very introverted, and it's like, get involved with the community?
Well, and I think that's so important too. Yeah, no, you're absolutely right. But I think that's also really important, just to draw on kind of what Stephanie was saying about using a strength-based model. Because even introverts have interests, and so maybe it's just a matter, I know we've all heard that old adage a million times, meeting the client where they are, and so even dealing with a client who's maybe a little introverted, maybe their forte is art, and so maybe it's just a matter of, trying to find something that they can use to express their artistic side. or feel like they are tapping into that skill or that skill.
And I will
But yeah,
also
and I
say,
love it.
as we
Go
were
ahead,
talking
sorry.
about the warm handoff, I
And
think. Sorry.
what I was going to say is, I'm from New York, but I'm living down here now in Florida, and I find that I'm very surprised that a lot of the libraries have so many programs for kids.
Oh, yeah. Mm-hmm.
So many. I'm very impressed by that.
They're very good, yes.
They are.
From a New York person to another New York person, I can attest to that. So I really appreciate something about the libraries here in Florida. So I heard the accent and immediately I was transported back to Fifth Avenue and I just got honked by someone. But in the hands of the warm handoff is like, not just, when we're working on a strength base and we're working with these kiddos that might be more introvert, that we might not know fully what they want to explore. In the warm hand of like taking it, like I know on our stand, because we can actually do a little bit more community work with their clients. We can go to maybe explore with them. I've gone with clients that might be interested in, comics or playing cards or playing video games, and they have a lot of places around here in this area that maybe a one hand up not doesn't look like it's service to service, but it might look like service to community, where you go with the client and do something and introduce that with the family, rather than just thinking always in the mentality of like, oh, we have to refer them to a service per se, but also like taking them to the library and exploring within the library. Here's the library calendar. Here are all the different activities that you can see throughout the whole month. Which one would you be interested in for me next time to come with you, and do a warm handoff to that, so that way when they're doing it, they know already, oh, that would be something I'm interested, or I tried it with the therapist or the mentor or the case manager, didn't quite like it, let me just go to another one. So that way, in a way of warm handoff, it's a little bit different, and it might be in a way of innovating yourself within the space, and I think it's a great thing to integrate the client within the community itself. Here, the libraries and the resource centers have a lot of resources and a lot of activities, especially for the summertime. I was just walking to one yesterday, and it had like a where I know it's like a little low, but for the students it is a lot. Like, if you do this community service, you're gonna get paid $50 if you come every Saturday here to pay in this area. That, for a kid that may be in ninth grade, 10th grade, that might not be passionate about doing something like that, might motivate them to get out of their home and do something, even if it's just for a lower rate or something that might not be like super wow for them, but it still gets them out. And one step out in community integrated, it makes it a lot easier. I'm working with a client that
Contingency management.
yes, I had a client that just recently moved from Miami here to Kissimmee, and if anybody has visited Kissimmee, it's a huge city with a lot of things all sparse around. So to get from one point to the other, you gotta have a vehicle. So this person is like in Miami, in the heart of Miami, walking distance from everything that they could actually find. Here in Kissimmee, now they have actually to rely more so on what is available in that community. And Kissimmee sounds like a city, but I call it the farm city, because it has a lot of farms and a lot of farmlands around, and what is available for them in those spaces. And so far we have been able to identify some things in the community for them to be able to engage in the downtown area, and with the support of their families, and seeing in a different way of how to integrate someone within their own space so they can feel supported and feel part of.
Awesome. So moving along to our family functioning. Somebody from that group want to chit chat to us about what you guys talked about? And again, there's no right or wrong answer. We're just hanging out.
Okay, so
Go ahead.
yes, this is Faith Allen. I initiated speaking about 211 services to tap into that. There are so many different areas to 211 that the families have no idea. what I tend to do is when I have a session with them, because the families are overwhelmed, frustrated at times, I just don't give them the information. I sit with them in a session and I carve out a time that we call 211, engage them in the different services that 211 offers, because it's a lot. And they're more inclined to participate at that level when you're with them than giving them the information and you leave. It's just another part of information for them. But if you sit with them, even 15 minutes, 20 minutes, and they're able to hear what 211 offers, the different services in the community for them, they're more inclined to participate immediately.
And to answer
And
your
they're
question,
adding feedback
Reverend Robin,
in real time.
yeah. So 211, for those who don't know, it's a resource hotline. You can literally call 211 and say, anything from I need a food pantry to I need a domestic violence hotline to, I have somebody who might need to be hospitalized. 211 will either connect you directly or they will give you the contact information to get that connection. But I loved what you just said. Yes, thank you so much, because I think that's so important. And I've said it a million times during this workshop about hand-holding, right? And sometimes some folks just need more hand-holding than others, and that's totally okay. And that's kind of our role, right, as helpers within the community, because we're all helpers within the community, regardless of what your role is. And so sometimes that is sometimes the biggest barrier, is themselves, right? And that fear of making those calls. We know it's not a scary thing, but just the anxiety that can produce for a family, or a family member, right? Or a parent or a caregiver who already has so much on their plate, having somebody just sit with them and helping them kind of siphon through the referrals and the phone numbers or the contact information or all of the people that they're talking to. That can be more helpful than making those calls for the family, right?
Mhm.
Again, because it's showing that partnership. So yeah, I love that. But yeah, we want to increase and improve that family functioning, and part of that is doing exactly that, right? Sitting there with them and making those calls and showing them that it is not the best experience, but it's doable and it's not scary, and it's an anxiety that they can handle because it's hopefully going to get them some sort of resolution, right? Okay, so we don't think we had anybody for our last, or we didn't have a group for our last.
For our last group, and I think we can and we can definitely talk into this one, you and I, Emily, because I think we work so closely on stabilizing clients at symptom level, as clinicians. And usually I think the best way, and I think that's why we have it listed here, is prioritizing symptoms. Which one is the one that's creating the most impact to their daily life activities, and targeting one sometimes makes that domino effect to the other ones. As clinicians in the treatments area, sometimes it's difficult because again there's so many priorities competing at the same time, and these are, just so you guys know, these are our 4 performance measurements, where these are our outcomes, where we measure our progress for our clients. And in that process, these 4 areas, how can you even prioritize one over the other? So as a clinicians, we're working on, okay, what is the one that's making the most impact, how I can either teach or coach a skill, and how I can process that with that individual and actually do a real live practice. Because again, given the positions that we are in the CAT team, we're able to go into the community and integrate those strategies in therapy as well as in mentorship. And we're able to provide those services a little bit more integrative within the community to improve that daily functioning and track and as we track it, see the improvement throughout the day. And sometimes, sometimes it's just, that part of like maybe this food insecurity. And as we're working to access that, and that's causing many other areas, maybe the anger stemming because I'm so hungry that I'm being all day. I haven't had anything to eat, so I don't know. My focus is is solely on this. But when we're working on those coping skills, those emotional regulations, and we work on the community and real life solutions, that might shift and make a whole domino effect of stability within the family and for the family.
Yeah, agreed. And we talked a little bit about mentoring, which it's not, this is not like me to not have blown your guys' eardrums speaking about mentoring, because I cannot speak more or more highly of mentoring and the imperative nature it is, and it has in the work that we do. Skill coaching, right? Yeah, people learn that in therapy, but where is the application, right? And how, if they are applying it and they're coming back to you and they're saying, oh, I did this and I did that, where's the gauge, right? Are they just lying to us because they were nervous about not doing their homework before the last, in between sessions, or what have you? And I'll tell you a brief story here really quickly, about mentoring and about this symptom-focused skill coaching. So we have had, and a typical length of stay on the CAT team is, I would say, like, it's designed to be short term. It's designed to be 3 to 6 months. The reality on Orange Cat is, the Orange County CAT team, it's probably between 6 and 12 months, if I'm being totally honest. So given that, we had a boy who was on the team. His brother was actually also on the team. And they had been on the team for going on, I want to say, like 10 or 11 months. And they were seeing our therapist regularly, the case manager regularly. They were great clients. They had a lot of behavioral issues, but the mentor was consistent with them, and everything was going well. So one of these boys, he started kind of like backsliding in his symptoms, and he started becoming more defiant. And the mentor took him out, and he said, and my mentor's name is Chris. Mr. Chris, I really want to go window shopping today. Can we just go window shopping and just walk around? It was a really nice day. Mr. Chris said, sure, we can go window shopping. So he takes him to a shopping plaza, and they were in that store Five Below, and just walking around, and my mentor started noticing this kiddo's body language kind of shifting and changing. So he just did a quick, check-in. Hey, you okay? Everything all right? And this kid had a toy or, a trinket or something in his hand, and he was walking around the store with it. And when the mentor asked if he was okay, he launched into this tirade about, Mr. Chris, I come from a long family history of thieves and people who steal and people who rob. And it would be so easy for me to just put this in my pocket and walk out, and I wouldn't have anything, no one would catch me, and, blah, blah. And he's like going on and on about how he could like steal this thing from Five Below. So my mentor was like, okay, well, that's true that you may not get in trouble with the law, but is that really what you want to do? What have you learned in your therapy about like being open and being honest about these sorts of things? What is it that you want for yourself? Do you want to be like your family members who you have just said are a family of thieves and robbers and, things like that? And he was like, I don't know. It'll be really easy. It would be nothing. It would be nothing. I mean, you wouldn't be mad at me, right, Mr. Chris? Thankfully, Mr. Chris didn't answer that. He just kind of put it back on him and said, well, how would you feel? How would you feel about doing that after the fact? So my mentor was keeping an eye on him, but let him, have a little bit of that autonomy and continue to walk around the store. My mentor was watching him and things like that. And shortly after, the mentor came and said, all right, are you ready to go? Because there's a couple more stores that they wanted to hit. And this kid was like, he's still holding on to this thing. And he puts it back, not in the right place, But he puts it down and he said, you know what? I don't want to be like that. I want a different life for myself. And I can't believe I'm saying this, but I don't want to do this. And that was it. That was the end of the day. And I don't know if that kid ever even gave a second thought. But for us, when Chris came back and he reported this to us, it was, this was a practicing of his skills in a real life situation. And he made the right choice, right? And it wasn't anybody breathing down his neck. So that's the kind of symptom-focused skill coaching in a team environment, and that's how it works, right? And that's a positive example of how it works. Does it always work? No, but in this situation, it worked, and it worked beautifully.
So, any other suggestions, strategies that you guys have on your end, or any questions about this?
All right, excellent.
Alrighty.
So we're going to kind of fly through this next section. So we have a little bit of extra time at the end to do another brief activity. But just to give you guys a little bit about our data and our outcome measures. So down here at the bottom, kind of the legend, you'll see the days in school, days in community, the NCFIS, and the CFARS or FARS. So the first two, the days in school and days in community, are kind of like those integrations that we were just talking about. How many days out of the month are our kids staying in school, or are they attending school? If there's, 20 school days for the month, are they attended? Have they attended all 20 days, or have they attended 4 days? Tell us. It gives us a good kind of aerial view of what is going on academically. Days in community, you might have guessed it. How many days are they staying home? In terms of, have they been arrested? Because that pulls them out of the community, right? Have they been hospitalized, right? Because again, pulls them out of the community. Have they unfortunately been removed from their home and they're no longer there? Again, pulls them out of the community. The NCFIS is the North Carolina Family Assessment Scale. It is a multi-domain. Sorry, what was that?
It's a multi-domain, yeah. Family functioning assessment that we do at intake and at discharge of the when the clients are working with us. And the CFARS and FARS, I'm hopeful that everybody knows what these are, but these are our symptom-based assessments where we assess periodically the client's efforts that they're making throughout treatment and how are they improving symptom-wise. So the CFARS will be for children, FARS will be anybody 18 years or older. So where we assess about 9 areas of symptomology that, and we progress it. I think it's at 90 days. We do a reassessment of the client's symptoms to see where we're going or how we are improving. And then that's where our reporting comes into. This data, just so you guys know, is from 2024, 2025, because we're still in our fiscal year in this month. And by the end of this month, we'll have more updated data. And the biggest impact, I would say, for our school days has been COVID. There has been a lot of students that have transitioned into virtual school that have now reintegrated back into their school or their academics, and they're still working on the pivot on the areas of reintegrating back into the school setting or academic setting in any sense. So there's still some reminiscence, even at 2026, there's still some reminiscence from COVID times that are still being observed within data.
Yes. All right. So for the area of school attendance, we, as a team, we achieved an 87% in school attendance. That means of 100% of days, the clients who were enrolled in the CAT team were attending 87% of those days. But those barriers, kind of like we've talked about already, transportation, illness, flat out refusal. Are they getting suspended, expelled, pulled out of one school to have to go to an alternative school? That all takes time, and that takes them out of school. Have they been arrested, hospitalized? Have they run away? And that's not something that we've talked about, but there are frequently children on the team who run away. Are there zoning issues where they're not familiar with which school they're supposed to go to, or they're zoned for one school, but they're really trying to get into another school? And kind of a little bit about what we talked about in terms of strategies. the coordinating and the helping of the coordination of those IEPs and those 504 plans. The identification of mental health staff within the school, social workers, school resource officers, who are the safe people. And then, of course, because we are a community-based multidisciplinary team, our therapists and our clinicians are able to go out to those schools and provide those services. I have a girl on the team right now who hated going to school. She was never going to school. The only reason she started going to school was because her therapist was seeing her at school to provide school appropriate therapy and therapeutic care. And so if that was something that got her in school, awesome. It was a great incentive for her to go, as well as get the treatment that she needed.
So for community integration, we actually hit this from our last fiscal year at 97%, meaning that our clients were engaged in the community, not being baker-acted, arrested, or taken into the Department of Children's and Family Child Welfare Programs, or into foster caring. And, as we were talking into the community integration is preventing those higher levels of care or those higher levels of systems to interfere or get in the midst of the families that we serve, and also educating our families and showcasing what is available, like the lovely 211 resource that is available here in the state of Florida and throughout all the other states, and making sure that the family knows where to and what to do, and where what these resources are available for them in the community. And there's also some areas in different areas in Florida that the resources that might be a little bit scarce and might be a little bit more difficult to access, but at the same time is that in hand holding or that integration that we work with them to make sure that those barriers can be minimized, and making sure that they can maintain a sustainability within those spaces in the community. Next slide. For family functioning, this is my area of niche. I love working with the families. I cannot stress that much. We hit a 94% based off our last fiscal year, where families improved their functioning within the families. And I think it attests of all the good work that we do here, as well as the good work that the community does. Because again, it's often and none, we're working really, really, really closely with other partners within the community, where when we step down a family, they move into maybe another type of service, and they continue working with the family. And sometimes it could be, like I would say, like the library, and they just continue services with the library, the YMCA, the different services within the community. And again, even the natural support that they can actually achieve within their own family, because sometimes we have families that live in the same home but different worlds, and making those connections within themselves is what makes a huge difference.
Yeah. Also, too, this is also, the NCFIS also encompasses physical safety. So it does take into consideration, Central Florida, unfortunately, has a ridiculously high rate of human trafficking. And so much of that is coming from the population that we serve in terms of age. And so, keeping that in mind and always in the back of our minds as a potential negative for that family. So the NCFIS also does take into consideration, proximity to highways, and, what that could potentially mean for a child or a family's safety. And then finally, for our CFARs, we hit 95% of the kiddos that we served in the last fiscal year had a decrease in their CFARs, which means that their overall symptoms were improving. And again, like we've talked about, some of those barriers and why maybe that could realistically probably never really truly accurately be 100% is, sometimes things happen. Right? Natural consequences. Sometimes the best and only way somebody might learn is through a natural consequence, whether that might be, juvenile justice commitment, so things like that. So again, improving symptoms has a direct relationship and a direct correspondence with activity, in the community, for example. So again, our mentorship and linking them to mentoring activities to continue expanding on those strategies, as well as community integration. Every so often the teams have mentoring events. And so that's a great time for, kids to meet each other. And is it our hope that they're going to become best friends? No, of course not. But for them to also not feel alone and not feel like they're the only one in this world that's fighting that battle, like that's what it's about. Because it makes them feel like they are part of something bigger, because the reality is that they are part of something bigger, right? So, right.
So we're close to 30 minutes, so we're going to showcase you guys some of our stories quite quickly, and we're going to pivot from this to our case analysis. But this is one of our stories. We have a family sending this lovely message. The cat thing was a blessing to our family. Obviously, we de-identify the whole success story. So we don't have any names of any of our staff in or families. The therapist and case manager were always available to help guide us through a difficult time. We're forever grateful for all their help. I don't think words can describe how much of a blessing CAT team has been, not only for the individual, but for our entire family. We were originally started working with them. I was worried my son was heading the wrong direction. Little did I know how much our lives were going to change, and all the health struggles my son was going through. Mind you, this is a family that had to relocate to Tampa area just because the client had a medical condition that was only being able to be helped in a hospital in the Tampa area. So we were able to support this family in that whole transition from being in one of our counties to moving into Hillsborough County and being able to continue that aftercare and do a warm handoff to the Hillsborough County CAT team as well.
So I'll let you guys I'll let you guys read this one, and then I'll move it along. But I received another success story from one of our families just earlier this week, and it was a little too late to add it to the slide deck. So I'm just going to read it to you as you have the opportunity to kind of peruse what's on your screen as well. But this one family said that the CAT team helped me so much in so many ways, starting off by sending the therapist. She has helped me by showing me how to stay on track with my medication, giving me coping skills, and letting go of my bad habits. I also thank the mentor for being the best mentor he could be and for always being there for me. I want to thank the CAT team for helping me get through these challenging last 2 years. This child was really, really struggling with bipolar disorder. And what's interesting is that he is not of the age to effectively or clinically be diagnosed with bipolar disorder, but he was having all of the symptoms. And again, we're looking at the symptoms, right? And so we're teaching him how to manage those symptoms. And it got really, really dark for him for a really long time. And so his father then said to us, as his father, I want to express my sincere gratitude for the CAT team for the incredible support that they've provided to our family. The guidance, encouragement, and commitment have made a tremendous difference in his life. I especially want to thank the therapist for her calm demeanor, patience, and dedication through this process. She has helped him stay consistent with his medication, develop healthy coping skills, and work towards letting go of bad habits. Her steady support and understanding have been instrumental in helping him grow and overcome challenges. I'd also really like to recognize the mentor for being an outstanding mentor. Beyond his guidance and encouragement, he took the time to connect with my son through basketball and other sporting activities. And those moments not only helped my son build his confidence, but also created opportunities for mentorship, life lessons, and positive role modeling. Knowing that he was always there for my son meant more than words can express. And that's like the best, really, truly, that is the best. So, all right, so I'm going to read you guys effectively a case study. If you give me just a second. Pull it up.
And as Emily's looking for to read that case study, we're gonna do something similar as we did earlier. We're gonna break into some breakout rooms. It's gonna be a shorter breakout room, just because we're shy of time. So we want to make sure a good 10 to 15 minutes for the breakout rooms to discuss, what strategies within the ones that we have talked so far, and which one do you guys think within those spaces makes will be the first priority that you will want to work on as a team?
All right. So, client is a 16-year-old Caucasian male. He was in residential treatment from August to October, transferred to another residential treatment from October to December for both mental health and substance abuse. He was kicked out of the first residential because during a group therapy activity, which was he drew really distasteful things and wrote very distasteful things towards another client. He became very escalated verbally, and instead of punching someone, he punched the wall. He states that he often punches walls when he feels overwhelmed. Client's substance abuse history primarily consisted of nicotine, marijuana, and alcohol, but he's engaged in substance use in early adolescence with cocaine, mushrooms, cough syrup, and acid. Client has had one Baker Act in August of 2025 where he escalated due to an argument and locked himself in the bathroom with a knife, stating he was going to kill himself and police had to intervene. He has engaged in self-harm in the past with any sharp object he can find, and he cuts his upper thighs, but he has not done this since the beginning of his residential hospitalizations. He's currently attending Florida virtual school due to his behaviors at school, which consisted of skipping school and if attending school, skipping classes, smoking marijuana on campus, which led to him having to do a program for 2 years as he was caught with marijuana at school. He struggled to complete the school drug program, and his mom removed him from the school, and that's why he got enrolled in virtual school. Client was in an outpatient counseling program from age 12 to 14 and stopped services with the counselors when his behaviors, substance abuse, and academic issues continued to escalate. He eloped from the home, where on one occurrence he eloped to his friend's house, taking the bus transit system, but he was intoxicated with alcohol and passed out in front of a cop. There have been no official DCF reports or cases, but mom has reported that he has said statements to peers, family, and neighbors that were untrue, but neither could give information on what those comments were other than they were crazy. He has an elevated risk due to being a step down from residential placement. He has an extensive substance abuse history as well as severe behavioral and emotional dysregulation.
Alrighty.
All right.
So we're gonna jump into about 10 to 15 minutes. I'm gonna put a timer on my end, and we're gonna be jumping into the different groups to, chime in and answer any questions that you guys have. Any questions so far before we go into the groups? All right.
All right. So we'll do a 15-minute group so we have a little bit of time to chat about after. And I think we could do the 3 groups again. Maybe not the same people, but we can break out in the 3 groups again. All right. Thank you. All
Alrighty.
right, that was fun. Sorry we didn't have as much time as we thought we would. But yeah, let's hear it. What'd you guys come up with? Don't all come at me at once, guys. Come on, I'm only one person.
Well, engaging him with substance abuse treatment, one-on-one, sponsor, someone in his life that is following him and watching the substance use stuff, who can point out to him relapse triggers. Hey, what do you do if I'm walking down the street and somebody comes up and says, hey, want a bump of Coke? What do you do in that moment? What do you reach for internally to not take that bump of Coke? Useful skills when it comes to substance use. Where it really, talk with him about people, places, things that could trigger him, that he needs to avoid, and people, places, things that he needs to embrace and bump up in his life, if that makes sense.
Yeah,
I think it is important, especially for a case like this, thinking about in a holistic way of like, yeah, it's not just thinking about the mental health, but also thinking about the substance misuse, because again, that could also lead to an impactful and low functioning. So it's making sure that that's something to think about and what strategy.
That's self-medication right there.
yeah,
It could be.
definitely.
Yeah.
Awesome.
All right.
Anyone else?
Maybe just trying to figure out which is the substance abuse or the mental health, which one's the bigger problem at the moment, and kind of sticking to that one, because we know that if a child is using substances, that sometimes their mental health is because of the substance misuse it's causing them and those behaviors. And our nurse even suggested getting genetic testing as well.
It works.
I love that.
Yeah, I think when that's something I was when I joined the group, and when I heard that, I was like, thinking of not just in the mental health perspective, thinking in a holistic way, mind, body, and spirit, and seeing it in more in a, because there could be some underlying medical conditions that could be triggering some of the behavioral issues that they're experiencing, or the substance misuse, and engaging in a genetic testing or even a gene side to make sure that the clients can actually have the best medical management that they can have, and actually that caters to their symptoms so they don't get exacerbated. Because again, undiagnosed medical conditions could definitely lead and impact mental health.
Yeah, for sure. Anybody else have anything to add before we kind of wrap up?
Let me ask a question. Do we have any previous charges like felonies and arrests? Because I know with DJJ, they have a lot of programs where they can have him committed to a program that will work on both far as the diagnosis of his so that they'll coincide together with the mental health and the substance abuse once he's committed to those programs.
Yeah, that's a great question and a great consideration. This particular client does not have any, and he doesn't have any DJJ involvement, even currently, not in his past and nothing current. But yeah, that would be a great avenue to pursue, for sure, and more collaboration, right?
Yeah.
So, awesome, I love that. Anybody else? All right.
So I would want to say thank you so much, everybody, for joining us and having us here. And it's spending this past 4 hours in this conversation. There's additional resources within the PowerPoint that you guys have access to, where you can find the guidance document. You can also actually also find the treatment plan, the treatment map, where you can find the different CAT teams in each one of the counties which I think is highly, highly important. The specialty treatment map is highly, highly important, as well as the mobile response team's treatment team map as well. You'll find all the ones that are around your communities with their phone number, who is the agency that's allocated for that. And it's important, because, there's so many resources out in the community and not knowing how to access them. But if you click on those hyperlinks, you'll be able to navigate that system. They just updated it just a few months ago, and it looks a lot easier to navigate and actually find within your county. And you can click on each one of your counties, and you'll kind of have a layout of all the different services within that county itself. I really appreciate the time, because I know it's an afternoon meeting and workshop, so sometimes it gets tiresome after the lunchtime. But I really, really appreciate everybody for joining us. At the end of this slide, you have my contact information. You're more than welcome to reach out to me whenever you have the opportunity to. I respond quite rapidly. Email, or you can call me to my extension. I'll respond to you quite rapidly. And I really appreciate also the assistance from FADA and DCF and our managing entity to provide us this space to be able to share some of our information. Emily's information is here as well if you also want to reach out to her. She's notorious to be emailing and contacting people even during at any time, and she is fantastic. And and she's my partner in crime in all this process.
Yes, thank you guys all so much for taking your time out of your day to attend. Certainly take my email address down or my phone number. If I don't answer my cell phone when I, with the ear, just text me. I'm super fast, like Lyanna said, in responding to my emails and text messages. Phones get a little sticky and a little hairy just because there's always multitasking to be done. Super special shout out to all the MRT folks out there, especially our own MRT. We couldn't do what we do without all of you guys and all of your support from the community. You guys are all invaluable to us. And so, again, to echo what Lyanna said, big thank you to DCF and to FADA. And I believe Robert has a couple of words for you all in terms of how to get your CEs and all of that kind of good stuff. So until we meet again, you guys, you make good choices and keep wearing those white hats.
We'll wrap it up to Mr. Robert.
Unfortunately, that is all the time we have for today. We hope you enjoyed this workshop. Thank you so much, Lyanna and Emily, for your time and the wonderful presentation. If you have any questions related to today's presentation that were not answered during our time together, you may contact Lyanna and Emily via the email addresses on your screen currently. Please note a couple of business items before we conclude. The evaluation will automatically populate at the end of the workshop. You will also receive a follow-up email from Zoom in 24 hours with the evaluation link. The evaluation deadline is 3 business days from today. If you have questions or need any assistance, please email us at training@floridabha.org. Certificates of achievement will be emailed to the email address you used to register for today's workshop within 30 business days. For licensed healthcare practitioners, CEUs will be reported to CE Broker within the same time frame. You must have attended the entire workshop and completed the evaluation to earn a Certificate of Achievement or CEUs. We are not permitted to provide partial credit. As a reminder, the recording and materials used in today's workshop will be available on the FADA website within 30 business days. To access the recording, PowerPoint, and participant activity guide, visit www.fada.org, navigate to the Resource Center, and click on Training Library as shown on your screen. Thank you for participating in today's workshop. Again, thank you, Lyanna and Emily, for all the work you put into this workshop and all the valuable information you shared with us today. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's workshop. Have a great day, everyone, and please hold for the evaluation.